Excellent. Just mute this. Hamza bhai, just put everyone back on. Just
I'm
put a
leaving a
message.
message
We're
for
on.
everyone.
Excellent. Okay. You're still not ready.
We understand the
We'll do one step at a time. Let's not worry about that video right now. Let's just go live first.
It's live.
And we YouTube live?
Yeah, YouTube live.
I'm muted, right? Okay, Hamza bhai, just check if we're Rida YouTube live. Let's just check that.
It's a 4 minutes timer.
No, you need to put a 10-minute timer on.
Okay.
Let's put 10-minute timer on. Because there's no attendee right now. There's no one in. So are attendees allowed to just come in, or do we have to permit them, or?
No, they can just use that link to join.
Okay. So let them now come in. Put a 15-minute, actually just extended to 15-minute.
So you're not mute on YouTube. You need to mute your thing on Zoom.
So we need to test out the attendees just to see their mics and everything are working properly.
Hello, Rita, can you hear me? Am I audible?
Yes. Yes, I could be fine.
Okay, play your video.
Importance of a good night's sleep for overall health and well-being. We are excited to present the USA Sleep webinar. Powered by Pulmonx Plus, a state-of-the-art pulmonology and sleep clinic in Dallas, along with Texas Sleep and Diagnostics and American Muslim Today, brought to you by Khan Clinics. We welcome you on this enlightening journey into the world of sleep medicine. Discover the importance of healthy sleep for adults and children, and learn why sleep health is crucial for overall well-being. Did you know that Pakistan has only one functional sleep clinic for its entire population of 22 million? Comparatively, India has 500
Jeremy?
sleep clinics throughout the country,
Jeremy?
and the US has more
In
than
between, you'll play this
2,500
again.
certified sleep
Okay.
centers.
So welcome.
This webinar aims to bridge the gap by bringing together renowned sleep experts from Pakistan and connecting the community. We aim to create awareness and initiate a step towards better sleep practices. Dr. Amir Khan will be your guide on this journey into the world of sleep medicine. During this webinar, we'll discuss sleep disorders in adults and children, explore sleep training techniques, and most importantly, understand why sleep is crucial for your health. Whether you're a doctor, medical student, or simply interested in better sleep, this webinar is for you.
Let's have Dr. Hamza. Dr. Hamza.
Hello and good evening, everyone. And welcome to our webinar on sleep medicine. I'm Dr. Hamza Sana, and I'm thrilled to be joined today by an esteemed panel of doctors from both the United States and Pakistan. As parents, we all know how important sleep is for our children, growth and development. But did you know that getting enough quality sleep is just as essential for adults? In today's webinar, we'll be exploring the fundamentals of sleep medicine and why optimizing sleep patterns is crucial for our overall health and well-being. We're fortunate to have a distinguished panel of experts leading our discussion today. Our course director is Dr. Amir Khan, who is a board certified in sleep medicine. Joining him are course coordinators, Dr. Wajiha Awan, Dr. Sufia Awan, Dr. Fatma Zera, Dr. Jannat Malik, nurse practitioner Brenda Wyrick, Ryan Brewer, and Marilee Bukowski. Over the next few hours, we'll be covering a variety of topics related to sleep medicine, including the science of sleep and how it affects our bodies, the importance of sleep for adults and children, common sleep problems and how to address them, and creating healthy sleep habits for the whole family. So gather your snacks and sit tight to begin this journey of enlightenment. Please also remember we'll also have time for live Q&A after every presentation. So just press the raise hand button on your Zoom screens and our admin is going to give you a chance to speak out. So be sure to have your questions ready throughout this session. We hope you'll join us for what promises to be an informative and engaging session. Without further ado, let's invite Dr. Amir Khan to officially start the webinar.
Okay, thank you for that introduction, Dr. Hamza. Let me just bring up my presentation. Slideshow. Just give a sec. Alrighty there. Why bother about sleeping? Before I dwell into my presentation, I want to just welcome everyone. Thank everyone for being here with us. It's just a very exciting opportunity. Our team has brought this presentation. It's powered by Khan Clinics, and it's with the help of Pulmonx Plus. So what are we talking today? We're talking about why do we bother sleeping? Why do I need rest? Why do I need to even sleep at all? Besides, I see it as an utter waste of time. I need to finish my work, really. That's more important. Sleep can come later on. It's not that important. Do I even have time for sleep? These are the common questions come to your mind when we think of sleep. So today, our aim is to change those perceptions and just try to bring in the fact that sleep is an integral, programmed DNA and the necessity part of your organism. It's for everyone. So if we can bring in that perception, and if we can bring that change in, I think we have served a little purpose here. For far too long, we think that you have taken sleep for granted. Our aim today is to think about paradigm shifts. We want to think that how can we change your mindset? So from today, let us think that we can enjoy sleep. And if you cannot do that, at least try to see it as, oh, we got to respect it. We got to appreciate sleep. And the least we could do is try to realize its importance. There must be a reason why it's been with us for 32 years of your life, and in some cases more. It always stays with us. So how are you going to think about sleep? Reframe your thought process again. That's what the question is. Is sleep something that you want to put in the bin at the end of the day? Not really. From now, sleep is something that you want to put right at the beginning, even before the day starts. It's something that you're going to do as a starting point and not think of as an end point of the day. Can we think that the universe, when it started, was all dark and then there was life at the end of it? Well, I think that's what happened. And that sounds the right sequence to me. It was night first and then day came. So let's reframe and think our mindset of being sleep is the start of the day, and then the other day starts, the true sunshine day starts. So if we can do that, then the next question comes, is there any living being on earth that does not sleep? Well, the answer is probably no. We know animals as big as elephants and giraffes sleep 4 or 5 hours. Other hunters as tigers sleep as 15 hours. Even birds need to sleep for about 15, 14 hours a day. But besides that, during migration, they may not even sleep for months. What about mosquitoes? They sleep for about 18 hours or even longer. And during their day sleep, they may have over 100 arousals or awakenings during the day. Ants, viruses, bacteria, all become inactive and sleep. And when we trace back how long sleep existed, it seems like we were over 500 million years ago when we think that the worms at that time were sleeping. So can we say that was even before the dinosaur era? I think so, yes. The dinosaurs, 250 million years, well before that, sleep was there. So can we think how sleep evolved? What is the question that we want to ask as has sleep changed in any ways? If we trace back and look at how humans evolved, our so-called ancestors, the apes existed about 10 million years ago. The Homo erectus, our pre-ancestors, 5 million years ago. And then the humans. But at that time, most of the humans were living on trees. We had to descend down to get the REM sleep. What is this REM sleep that you're talking about, Dr. Khan? Well, it seems like REM sleep is a phase of your sleep when you actually dream. It's a phase of your sleep when your body is paralyzed. Besides, you need to do that if you are dreaming so you don't act out. In your dreams, you don't kick, you don't punch, you don't shoot, you don't do violent things or anything. It was very, very important. So how do we think that the REM sleep mattered? It was an act to perform higher intellectual thinking. And that was very important. REM sleep, we had to descend somehow from the trees to sleep flat on a surface. And then that happened when fire came. It helped us to descend down. So how does the modern new ancestral sleep change from the newer version of the human being? The REM sleep increased drastically in amount. From the lower limits that existed before, it now in a modern adult is about 15, 20, 25%. Mind you, at birth, REM sleep is about 50% of your sleep. And it's needed for a good rhyme reason. What about non-REM sleep? The other half, that starts at about 22 weeks of conception. So humans start sleeping as soon as their existence comes into being, right in the womb of a mother. It's also very important. And we will discuss that a little bit further down. So how did sleep be defined? It's a state. It's a situation in your life when your reception, your perception of things, your 5 senses are blocked. Your response as a consequence does not exist. But what makes it different from death? And that is your receptions and your response is reversible. Is non-REM sleep has any phases? Yes, of course it has. It goes into stages of 1, 2, and 3. These are the deep phases of your brain. And how is it important? Well, it's important because that's when you rest, Max. That's when your brain restores. And that's when your brain reposes again. And it's the time when your memories get locked and your emotions are locked away properly. So are we saying that non-REM sleep is essential for that reason, for your memories and emotions? Of course they are. Because if you don't go through those phases, you're not able to concentrate, a key component. And what about the REM sleep we just discussed? We think that it made us the ashraful mahlukat. The REM sleep, why does the body have to be paralyzed? And just like I explained before, you don't need to be acting out when you are dreaming. So you have to be paralyzed. But another question comes about, why do we have to dream in the first place? We have to dream to be creative. And we have to dream to create those new neurons, new connections, and lock in and tap in from our memories. So it's very relevant that these two phases of sleep work together. Let's take an opportunity and see if we can look at the evidence of what is there for sleep. We want to be evaluating two aspects of sleep. A, your duration of your sleep. And B, what is the quality of the sleep? Throughout our presentation, we will be discussing about the quality of sleep and how that matters. My colleagues will be walking you through different diseases and pathologies that are relevant. But I'm going to shed a bit of light about what matters when you sleep less. There is a lot of scientific evidence. One of the key things we want to look at is there any mortality risk? A mortality or morbidity risk is when there is a death risk, a direct correlation. And papers and publications have easily, frequently, and a lot of times repeatedly shown that if you sleep less, you're in trouble. How much of sleep is enough, doctor? The question is asked a lot of times. So the answer is, just as a ballpark, it varies from one individual to another. But if you are sleeping less than 6 to 7 hours a day, you're literally in trouble. And you should not be doing that. So let's take the minimum, not 7, but 6 hours as a point of discussion for our publication. An association with that is that you tend have a 60% more chance of dying throughout your life if you sleep less than 6 hours a night. A follow-up paper with 9 years of data showed, yes, sleeping less than 7-8 hours is an issue. Also, keeping an eye on your weight is very important. Don't snack, which it showed in the publication. And in fact, of all the other things, alcohol, physical activity, weight loss, but not taking breakfast in the morning is also an issue. Is there more risk for other cardiovascular disease? Is there more risk for metabolic issues, i.e. diabetes? And is there risk for mental health disorders? And of course there is. And we will go through them just a little bit in a second. But let's ask the next important question. How is it relevant in non-REM sleep that we have retained our brain function? And one of the most important things, the ability to be able to recall stuff. There is a brain area that is called hippocampus. The hippocampus is considered to be the storehouse. And as soon as you go into sleep, and especially when you go into non-REM deep sleep, the so-called singing phase of sleep, stage 2 and 3, you should be throwing something that is called spindles. And these spindles are integral for you locking away your memories and putting your stuff in the brain so that you can recall it for the rest of your life. So this has been repeatedly been tapped. The signals, the neurotransmitters, and all the biological markers have been long well established. So what if you don't sleep properly? And like we said, you deprive yourself of sleep. Well, we see that there is a 40% reduction in your memory stores, i.e. your memory capacity. And if you sleep less than that and try to retain knowledge or accumulate, your hippocampus is basically a cold store, not computing any information. And what does that mean? You're just sitting there in front of a book and trying to read, but your hippocampal storehouse is actually dead. Does 40% even matter? Well, yes, it does, because that's the difference between you getting an A or an A plus and a D or C, which is a failure and or a fail. So are you saying if I have to retain knowledge, I have to sleep afterwards? Of course you have to. But not only do you have to sleep afterwards to keep those spindles and to keep those memory locked, you should be actually sleeping even before. So pre-learning is also very relevant. And you have to make sure that you're ready to accumulate that knowledge. Because if your brain is not ready, you're functioning 30% less in getting that knowledge into your brain. So this message for all of our students that are going out, you simply cannot ignore your sleep. Sleep before, consolidate, and sleep afterwards. What about the long-term effect on the memory? Well, a lot of publications have shown that dementia is exacerbated many a times if you deprive yourself of sleep. Sleep quality, duration matters. Let's have a look at a couple of other little evidence about the impact of sleep besides memory and besides the general mortality risk. What about the effects of heart attacks? And this paper published in the New England Journal showing when time shifts happened and in spring time moves forward and you lose an hour versus time going back in autumn and you gain an hour, it had a direct impact on those 2 days of the year on people having heart attacks. It's not a coincidence, and it's just not one time. These are studies for hundreds and millions of people. Was there any evidence of heart attacks with inadequate sleep? Other than that, tons of publication. The Japanese study for 14 years showed over 400% risk for having cardiac arrest in the population that they reviewed, over 4,000 patients. Atherosclerotic built 200% more when you had deprived yourself of sleep. And other heart attack incidences, a lot more when you are not sleeping properly. What is the effect of that? Let's just remember that you don't want to activate your sympathetic system throughout. We do not want to see the heart rate variability, and we do not want to see that blood pressure rise. It equals to stress. So sleep so you can lower your stress levels down. I'm just going to quickly go over this 2 bits so I can take some questions at the end. Immune system, very relevant. I want you to remember cells that are called natural protective killer cells. These type of T cells perform a very distinct function. They fight your cancer cells and they clean away any unwanted infections in your body. Bacteria, viruses, anything you name it, it cleans away. But what happens when you don't sleep? A drastic 25, not 50, but a 70% decline in your immune cells. And that's very relevant. You're depriving yourselves, you're making yourselves more vulnerable, and you also promoting inflammation. And those cleaning system that is in the body is essentially ineffective. I want to just quickly touch on one or two other aspects of sleep. One is the reproductive system, how it affects. Another is your core DNA structure. And this publication suggested that the men's testosterone level are hugely affected if you deprive yourself of your sleep. We know that testosterone is essential for your functioning, enthusiasm, race, and also for you to perform well. A dramatic drop in testosterone levels making you 10 years older than what your actual age is. Besides a 30% reduction in the quality and quantity of your sperms. And other studies from women, especially from higher intellectual women who are nurses, for example, publications showing menstrual issues abnormalities and effect on their FSH and other secreting hormones in the body. Not only that there is a 20% decrease in follicular stimulating hormone, essential part of ovulation, but a 33% more chance of menstrual abnormalities and a higher incidence of first trimester miscarriages. Message here, sleep. And not to mention for men, another correlation. Just keep this in your mind. And is there any effect of sleep, depriving yourself of sleep when on the actual DNA structure itself? Of course there is. In one study, they just analyzed patients after 1 week of sleep deprivation and noted 750 different points in sleep on the DNA structure that were affected by sleep. 750 different points. With that, I just want to conclude my presentation. And before we take on some messages, I just want to acknowledge my teammates, all of the physicians and providers here who are helping with this webinar. So far, fantastic and doing a great job. And also the rest of the team that have made this presentation possible to you guys. I want to thank you, and then we can take some questions. For the questions, let's have a hand raise from the attendees. There is a panel, there is a button there. If you click on that hand raise in your Zoom, you can ask a question. The other option is you can write a question if needed. So write and we can answer the questions. And if not, we will continue our presentation and do the question answer sessions after the next presentation. We have one question right now, and we'll try to take that. Can we unmute Bilal here? So we'll move on to the next presentation and try to take these questions after the next presentation. I'm distinctly honored to have my next presentee to present the topic of obstructive sleep apnea. Proudly, I want to present Dr. Sophia Awan and then Dr. Fatima Zohra. Both of these physicians are from Pakistan. So we're very proud to have them help us out and hand over to the stage to Sophia and Fatima. Sophia, obstructive sleep apnea, and Fatima will go over what are your treatment choices. Other than that, there is a Q&A part, and then we'll pause after the next presentation and try to combine both the talks, and in the interim, see if we can get live questions on as well.
Thank you, Dr. Khan. Good afternoon, everyone. I'm Dr. Sophia Awan, and I have graduated from Nawaz Sharif Medical College, Gujarat. And right now I'm working as a sleep virtual liaison with Pulmonx Plus. Today, I'm thrilled to be here with my partner.
Hello and good afternoon, everyone. I am Dr. Fatma Zahra, and I have graduated from Hamdard College of Medicine and Dentistry, Karachi, and I work as a virtual liaison at Pulmonx Plus.
We are very excited to be here today to discuss and create awareness regarding a very critical health issue, which is none other than obstructive sleep apnea, which despite of its high prevalence still remain undiagnosed in most people, especially in Pakistan.
Yes, Dr. Sophia, you are right. Obstructive sleep apnea is often undiagnosed in Pakistan. And today, through our discussion, we hope to impart knowledge to our fellows who have joined us today so they can spread our message as well. So let's start with the basics. Sophia, can you please explain what sleep apnea is and how it affects the individuals?
Yes, sure, Dr. Fatma. So obstructive sleep apnea is a type of sleep apnea in which is characterized by repeated interruptions in your breathing that can be due to a partial obstruction or a complete obstruction. And these interruptions in your breathing are known as apneas that happen during your sleep. These can last from a few seconds to over a minute and can occur multiple times over an hour. And this is not usually noticed by the person experiencing them until they wake themselves up by a feeling of choking or gasping for air from their sleep. The most common symptoms of sleep apnea include snoring, daytime fatigue, and interruptions in their breathing that are usually noticed by the patient's partner or their guardian. Obstructive sleep apnea can ultimately lead to various complications, including cardiovascular and metabolic disorders. Through our video presentation today, we would like to focus on understanding what obstructive sleep apnea is, its relationship with obesity, and the impact of oxygen desaturation and heart rate fluctuations during sleep apnea on our health.
And after that, we will be discussing how can we treat that and how should we proceed after getting diagnosed with obstructive sleep apnea.
Welcome. Today we're diving into the world of sleep apnea, a condition affecting millions globally. Our focus will be on defining sleep apnea and exploring its impacts on oxygen desaturation and heart rate. Obstructive sleep apnea, or OSA, is a serious disorder where breathing repeatedly stops and starts during sleep. These interruptions, or apneas, are caused by a partial or complete obstruction of the upper airway. Did you know that about 22 million Americans suffer from sleep apnea, with 80% of moderate and severe cases undiagnosed? In 2024, a study found that 23% of young adults in Asia and Australia have OSA, compared to 9% in Europe and 13% in the Americas. Despite its high prevalence, many remain unaware they have OSA due to easily overlooked symptoms. Symptoms include snoring, morning headaches, waking up unrefreshed, and daytime sleepiness. The stop-bang criteria, snoring, tiredness, observed apnea, blood pressure, BMI over 35, age over 50, neck size over 40 centimeters, and male gender are key indicators. Obesity is a major risk factor for OSA. Excess fat around the neck narrows the airway, increasing the likelihood of obstruction during sleep. Globally, with rising obesity rates, over 40% of adults in the U.S. are obese. OSA incidence is also on the rise, making it a critical public health issue. Fat deposits in the neck and increased abdominal fat reduce lung volume and add pressure on the airway. Obesity-related inflammation affects muscle function, contributing to airway collapse. Significant fat infiltration in the tongue can also cause airway obstruction. Oxygen desaturation has a great impact on our sleep and play a great role in sleep apnea. Normal blood oxygen levels range from 95 to 100%, but during apnea they drop below 90%, disrupting sleep and potentially causing long-term health issues. Apnea episodes cause bradycardia, a slowing of the heart rate due to reduced oxygen levels. Upon resumption of breathing, tachycardia occurs, with the heart rate spiking to reoxygenate the body. These fluctuations increase cardiac workload and risk of arrhythmias and chronic heart conditions. Over time, the strain on the cardiovascular system from these heart rate fluctuations can lead to severe health problems, including stroke, myocardial infarction, hypertension, and chest pain. In conclusion, the interplay between obesity, sleep apnea, oxygen desaturation, and heart rate fluctuations presents a multifaceted health challenge. Each component exacerbates the others, leading to a significant cumulative effect on overall health. Understanding sleep apnea and its impacts is crucial in addressing this widespread and often undiagnosed condition. Thank you for watching. This video is brought to you by Khan Clinics and powered by American Muslim Today.
Thank you, Dr. Sufia, for the informative video presentation. But I have a question regarding the levels of obstructive sleep apnea that were mentioned in your video. Could you please elaborate on that?
Yes, Dr. Padma, sure. So there are 3 stages of obstructive sleep apnea known as mild, moderate, and severe. And they are dependent on the AHI levels. So AHI is actually apnea hypopnea index that quantifies the severity of your sleep apnea by counting the number of apneas and hypopneas or the number of times you stop breathing during your sleep. So if the AHI level is from 5 to 15, it is regarded as mild obstructive sleep apnea. If it is from 15 to 30, it is regarded as moderate obstructive sleep apnea, and 30 above is regarded as severe obstructive sleep apnea. So, Dr. Fatma, now that we have discussed that obstructive sleep apnea is a very severe condition, how are we going to treat it?
Well, Dr. Sufia or anyone from our audience, have you ever heard of or seen a PAP device?
Well, I have heard about it, but could you please explain to me and to our audience a bit more about what PAP devices are and how can they be used to treat obstructive sleep apnea?
Yes, Sufia, for sure. Basically, PAP devices are the innovative devices that help people with sleep conditions, and they are very common in the US but not as much in South Asia like Pakistan. Using PAP devices help patients with sleep apnea during when their body stops breathing while asleep, reducing the risk of associated health problems. And today, with the video presentation, we will clarify how PAP devices work, their type, significance, and the latest advancement in the treatment of sleep apnea.
Welcome to our comprehensive guide on positive airway pressure, or PAP devices. If you or someone you know struggles with sleep apnea, this information could be life-changing. Today we'll cover what PAP devices are, their types, significance, new advancements in treatment, their use in children, and conclude with a summary and Q&A. PAP machines are the most commonly prescribed devices for treating sleep apnea disorders. Obstructive sleep apnea, or OSA, is characterized by periodic, partial, or complete obstruction of the upper airway during sleep. There are several types of PAP devices available. Let's explore the main types. Continuous positive airway pressure, or CPAP, provides a single set pressure throughout the night. It's generally more affordable, but may not accommodate changes in your breathing as well. Automatic positive airway pressure, or APAP, adjusts the pressure on a breath-by-breath basis. This can be more comfortable for new users, especially when breathing fluctuates. Bilevel positive airway pressure, or BiPAP, has two pressure settings, one for inhaling and a lower pressure for exhaling. It's used for individuals who cannot tolerate CPAP machines or have elevated carbon dioxide levels in their blood. Let's compare CPAP and APAP devices. CPAP provides a constant set pressure during inhale, while APAP adjusts pressure based on your breathing needs, offering more comfort for new users. Let's explore some of the new advancements in OSA treatment. These include oral appliances like mandibular advancement devices, Inspire therapy involving hypoglossal nerve stimulation, surgical options such as genioglossus advancement, and positional therapy. Mandibular advancement devices help reposition the jaw to keep the airway open. Inspire therapy stimulates the hypoglossal nerve, helping to keep the airway open by moving the tongue forward. Genioglossus advancement surgery repositions the tongue muscle attachment to prevent airway collapse. Positional therapy encourages sleeping in positions that reduce the likelihood of airway obstruction. PAP devices are also used for children with obstructive sleep apnea. They improve sleep quality, cognitive and behavioral functions, and even aid in growth and development. PAP therapy keeps the airway open during sleep, preventing interruptions in breathing that can lead to fragmented sleep and decreased oxygen levels. Consistent use of a PAP device reduces the risk of complications associated with untreated sleep apnea, such as cardiovascular issues, daytime fatigue, and cognitive impairments. Thank you for joining us in understanding PAP devices. Remember, a good night's sleep is essential for a healthy, productive life. If you think a PAP device could help you or a loved one, consult with your healthcare provider. This video is brought to you by Khan Clinics and powered by American Muslim Today.
Thank you, Dr. Fatma. That was a very detailed explanation. Well, I have a question for you. In the video, it was mentioned that there is an auto PAP for the CPAP machines. Is there something called an auto BiPAP as well?
Yes, Sophia, there is an auto BiPAP as well, and it's quite similar to auto CPAP, but in auto BiPAP, there are two different sets of pressures for inhalation and exhalation, and it automatically adjusts the pressure settings based on the patient's need throughout the night.
Thank you for the clarification. That was very insightful.
You're welcome, Dr. Sophia, and thank you to our audience for their concentration. We encourage you to reach out with any question or concerns you might have. Your health and well-being are our top priority, and we are here to support you in your journey to better sleep and overall health. Thank you.
Thank you, everyone.
Very superb. Very proud of both of the girls doing the job, doing this job. We have a couple of questions, and before I take a call from the audience, two questions came up, which I want to tackle. One from Ayan, and his question is, what happens if you do not treat obstructive sleep apnea? The complications of an untreated sleep apnea. I'll have Dr. Sophia answer that question.
So as we have already discussed this, that if you were not going to treat your CPAP with the definite treatment, that is the PAP therapy. It can lead to various cardiovascular and metabolic disorder. It can lead to myocardial infarction or heart attack. It can also lead to stroke because your body is continuously going into tachycardia and bradycardia. Your body is having oxygen desaturation, and as you know, the oxygen levels are going down. So it can lead to various effects on your health. Majorly, it can cause MI, stroke, and other issues as well.
Excellent. I totally concur with that. That's a brilliant answer. You don't treat sleep apnea, your sympathetic system is going to remain high. First effect is on the heart. And that's of very dire consequences. This actually answers another question that came up, is that my blood pressure, how can blood pressure lead to obstructive? Well, it's the other way around. If you do not treat, the question was, how does blood pressure lead to obstructive sleep apnea? It's the other way around, like I said. If you don't treat your sleep apnea, remember in the first talk, we said there is duration of sleep. And then the second bit is when the consequences, the quality of sleep, both have to be good for you to get a restful, awakened, refreshed sleep. So that's point number one. Point number two, the question of blood pressure. If you do not sleep, one of the first effects of sleep deprivation, we said, is mortality, that is death. Heart, because it leads to the sympathetic system being activated, the stress system to be activated, the heart rate to go up, and more consequence of atrial fibrillation. And the second thing, blood pressure going up. So your stress level is higher. A very strong association. In fact, a lot of cardiologists here will make sure that the person's blood pressure, if it's not getting better, and atrial fibrillation is not getting better, treat obstructive sleep apnea. So brilliant answer. That was part of both of the questions that it had. There was a couple of other little questions. Mind you, you can type your questions in Zoom, and we will try to get to them and answer them one by one. There's a Q&A bit which we'll try to answer. And then the second question that came about was, I've been treated for long time sleep disturbance, and I have been taking diazepam, but still not able to treat, still not able to sleep. Now, this is a question about insomnia. And our next panelist will be talking about insomnia. So I'm going to defer that question to the next presentation. We have 3 more presentations that will come up. Insomnia, sleep in kids, and restless leg. And we're going to touch on all of those topics. Just to refresh, after that, we'll have a short break and do a case study about this. And we want you guys to participate a little more than usual. So we have in the audience, our first preference is try to come on Zoom and ask the questions live. We have 2 participants who want to ask questions and have raised their arms. Iram Bilal is the first one. Iram or Bilal or Abdullah, whoever can come on and ask a question, we'll be happy to take those so we can keep moving the flow. And we're making a note of, and FYI, we are making a note of the questions, and we're going to try to answer as many as they come in between the talks and some afterwards. But like we said, our preference is going to be you coming live on Zoom, on the Zoom, and asking questions. Let's take a question for Iram and Abdullah, if they're ready.
Hi, everyone. Firstly, I wanted to say thank you to Dr. Khan and rest of the team for organizing this informative webinar. So the question pops up in my mind is, I know someone in my family who suffers from sleep apnea. Are there any common treatment options for sleep apnea? Thank you.
Thank you, Iram, for your question. We'll have Dr. Fatima answer that question. Fatma, since you covered treatment options, someone is saying they have a family member who has sleep apnea, and they want to say, what are the treatment options available right now, and what can they do?
Yes, so very good question. So the ultimate treatment for sleep apnea is PAP therapy through CPAP or BiPAP, as we have already discussed in our video. But we have to assess the patient AHI first, which is apnea hypopnea index. Then we will decide either we will go with the PAP therapy or the conservative treatment. So if patient's AHI is less than 5, so we can give them a mouth guard or any new therapy like genio therapy or inspired therapy. But ultimate treatment, like if the patient AHI is more than 5, so the ultimate treatment is PAP therapy, as we have already discussed in our presentation, like CPAP, BiPAP, or AutoPAP.
Excellent, excellent. So you can give PAP therapy, you can give a mouth device. And the next question, actually, one from one of the audience is, what factors make sleep apnea more likely? And this I'm going to ask to Dr. Sophia because it ties in with a lot of other questions that people have. Sleep apnea, if you have that, and if you're snoring especially. Dr. Sophia, just in a few words about that answer to that question.
Well, if you wanted to diagnose sleep apnea,
What factors make sleep apnea more likely? Snoring is one, and what else?
Yeah, so the first one is snoring. Second can be choking or gasping in your sleep, shortness of breath during your sleep. Then there can be daytime fatigue, daytime somnolence. If you're dozing off while you're driving or you're doing anything that you're working,
and
then
the risk factor. What is the risk factor?
Yeah. Well, it's mostly common in males, people who have high blood pressures. Then it can occur in people over 40 and who have more greater neck size, more than 40 centimeters.
And obesity.
Top brand criteria.
And the
BMI,
and
obesity,
that's the number one. But so the biggest risk factor that you're absolutely right. But the biggest risk factor for obviously, if you are obese, and what's the BMI, Dr. Sophia, that you worry about?
Greater than 30.
And what is BMI for the audience who don't know?
So BMI is an index in which we take the height and the weight of the patients. It's an index for that gives us and if it's greater than 30, then you should be getting worried about.
Excellent. I think that's you're absolutely spot on, and those are very relevant relevant questions. I think we've got a few other little questions. We're going to keep on taking these questions, and we're going to see if take a live question if possible from, let's see, Anam or Mirza Farouk. Anam Munib.
Assalamu alaikum.
Hello, walaikum assalam. How are you?
Dr. Khan and your team, very brilliant and excellent presentation. My question is how we measure AHI?
Very good question. I'll let Dr. Fatima answer that question. Thank you for the question, Mirza.
Thank you.
How do you, he's worried about what is AHI and how can we measure that? How can we get an idea about the apnea hypopnea index? Fatima.
So basically, apnea hypopnea index is, you can say, a parameter or marker to identify the obstructive sleep apnea. And as we classify obstructive sleep apnea into 3 levels, mild obstructive sleep apnea, moderate, and severe. So if patients AHI is 5 to 15, then we can classify it as a mild obstructive sleep apnea. But when it's 5 to 30, it's moderate, and more than 30, it's severe. And it can tells about the severity of sleep apnea by counting the numbers of apneas and hypopneas during the sleep.
Excellent.
Is there any role of Assalamu alaikum? Is there any role of benzodiazepines or in sleep apnea? Is there any role of benzodiazepines or sleeping pills in sleep apnea?
Gotcha, Bilal. Thank you for your question. So I've, like I said, benzodiazepine and insomnia. I've got your question and it's going to be put in the insomnia talk. And I promise we're going to answer that very quickly because benzodiazepine, diazepam, and a lot of little things are being very abused in the sleep world. And Akif and Dr. Vijaya are going to be touching on that topic. So hold on your question. I'm going to promise I'm going to get back to that in a few minutes. Anam, you got a question. Anam Munib is next on.
Hello, everyone. My name is Dr. Anam Munib. My question is like, what are the causes which leads a patient to develop sleep apnea, and how we can avoid it before moving on to the CPAP treatment? How we can avoid developing it? Thank
Very
you.
good question. Anam, Dr. Sophia, what are the causes and how can we avoid sleep apnea? So please go over that.
Well, in order to avoid anything that can cause sleep apnea, we have to avoid anything that can narrow our airway, first of all, like obesity, like large tonsils, like change in your hormone levels. Then we have to maintain a good sleep hygiene. We have to maintain a good sleep routine. That is what will be discussed by Dr. Bhatia, of course, and that can help us create a better sleep, and that can increase the quality of our sleep and ultimately preventing us from getting sleep apnea.
Excellent answer. I'm gonna put a time say keep on moving. Please note that we are keeping a tab on your questions. We're gonna answer all of your questions, so don't worry about that. But I want to move on to the next topic. Like I said, insomnia, after that kids, after that restless leg. And then we're going to have a short break. But the second session is all about case studies and lots of your questions. We would love to have them. And if we have time permitted, we may do a short little presentation about good tips for sleep, but that will be right at the end. Let's move on to our next presenter. Our next presenters are Dr. Vajia Awan, who is a physician in Pakistan, and Akif Salim, who is a pharmacist. And both of these doctors work with us in the States. You have the stage now. Thank you.
Assalamu alaikum, everyone. Good afternoon. Thank you, Dr. Khan, for the introduction, and welcome everyone here today. So this is Dr. Vajia Kiranavan, and I'm a medical graduate from Nawaz Sharif Medical College, Pakistan. Right now, I'm working as a sleep team supervisor with Pulmonx Plus, and my co-host is.
Hello, everyone. This is Akif Salim. I'm a pharmacy graduate from Government University, Pakistan, and currently I am working as a virtual pharmacist here at Pulmonx Plus.
Okay, Akif, you know that we will be discussing a very interesting topic today. In fact, around 30% of our general population suffers from it.
Yes, Dr. Wajiha, I am very excited for it. So, shall we begin?
Yes, sure. So our topic of discussion is insomnia.
Dr. Wajiha, what is insomnia? Can you please explain it?
Yes. Okay, so insomnia is a common clinical condition that is characterized by difficulty initiating or maintaining sleep. And it also characterized with frequent awakenings. And then after awakenings, it is difficult to return to sleep or awakening too early with inability to sleep. And it is characterized by symptoms such as irritability or fatigue during wakefulness.
Okay, and are there any types of insomnia?
Yes, Akif, there are 3 types of insomnia. I would like to give an overview about that. First is acute insomnia. It is short term and it occurs because of the life circumstances and it does not need any treatment. Then we have chronic insomnia. It is a bit longer. It occurs for a bit longer time period, for at least 3 months, but it requires treatment. And then we have transient insomnia. It is short term and it can last up to 3 nights. And it is temporary, and the sleep pattern will return to normal on its own.
So, Dr. Wajiha, can you tell us about the symptoms which a person should look for so he or she can consult a physician?
Yes, Akif, there are few symptoms that anyone should be worried about if they're experiencing dissatisfaction with sleep quality or quantity that may be associated with at least one of like difficulty initiating sleep, difficulty maintaining sleep, and early morning awakening. And if it occurs for almost 3 times per week for 3 months, then it is an alarming sign.
Interesting. And can you tell us, our audience, what causes insomnia?
There are various causes of insomnia. I would like to mention a few, which are underlying medical conditions, mental health conditions, irregular sleep routine, late night working hours, stress, poor diet choices and habit, and even sometimes jet lag and eating late at night. And there are certain medications that can cause insomnia as well. So, Akif, our audience would definitely be interested in knowing about the medications which can cause insomnia. So, would you like to give an insight on that?
Okay. Presentation. Vijaya, you keep on your presentation, please.
Okay, so insomnia, Akif, can you give an overview about the medications that can cause insomnia?
Sure, Dr. Wajiha. There are certain medication that we use and that can possibly cause insomnia. So these medications are like some antidepressants like fluoxetine, sertraline, duloxetine, and citalopram. And we have certain beta blockers like metoprolol, succinate, and atenolol. They can possibly cause insomnia. We have some CNS stimulants like caffeine, modafinil, methylamphetamine. They can also cause insomnia. Then we have decongestants medications like phenylephrine and some steroid medications like prednisone. So all of them have the potential to cause insomnia.
Okay, thank you, Akif. This must be very helpful information for everyone.
Okay, Dr. Wajiha, let's discuss about the evaluation of insomnia.
Yes, sure. So the evaluation of insomnia basically depends on following factors. Whenever a patient comes, then we have to take the clinical history, medical and psychiatric history. Then there are other options like sleep-wake diary, wrist actigraphy, sleep study, or polysomnography.
Okay, and Dr. Wajiha, our audience would like to know about the clinical history. Please elaborate a bit.
Yes, sure. So whenever a patient comes in, we can ask the patient following questions like the sleep itself, like when the patient goes to bed, and what are the pre-sleep conditions, and then impact of any sleep problems, symptoms of obstructive sleep apnea, which can also be inquired from bed partner as well if possible, other factors which may cause insomnia, and then naps during the daytime.
Okay, and what are the other tools and tests for the evaluation of insomnia?
Okay, so we have a few other tools other than the history. First is sleep wake diary, that is also called as a sleep log, and then wrist actigraphy, and then polysomnography and sleep study.
Okay, and what is sleep log and wrist actigraphy?
Okay, so sleep log is a kind of a document that we give to the patients to record manually their bedtime, as you can see here in the picture. This is called as a sleep log. And then we ask the patient to document the wake up time, their bedtime, how long it takes to fall asleep, the number and the duration of interruptions, and the number and duration of daytime naps. Whereas wrist actigraphy is just like you can say a digital watch, and I guess our audience, most of the people knows about the digital watches and how they work. So wrist actigraphy records all the data, all the factors I just mentioned in this form. As you can see the graph here, it will give the result in this way. So the only difference between them is that wrist actigraphy we have is automatic, and sleep log we have to fill it manually.
Okay, so that is very intriguing. Oh, and what is the treatment of insomnia?
So we have two treatment options. The most important one is cognitive behavioral treatment and medications. This is also very important. That is medication treatments. And our goal is basically to improve the quantity and the qualitative aspects of sleep.
And what is CBT?
Okay, so CBT, the full form of CBT is cognitive behavioral therapy. So the main theory of CBT is that our thoughts, feelings, and behaviors are interrelated. So I'm just trying to put it into simple words. With the help of CBT, we can find out the thoughts and behaviors which causes sleep problem, and then replace those thoughts and behaviors with the habits that support sound sleep. This includes all these factors, but here we will focus on, as you can see, the sleep hygiene, stimulus control, restriction therapy, cognitive relaxation. So here we will focus on stimulus control and sleep restriction therapy.
Very interesting, Dr. Vajiha. So our audience would be interested in knowing that what is stimulus control?
So as you can get the idea of stimulus control by the name itself, it says that stimulus control therapy basically designed to help individuals suffering from insomnia to strengthen the bed and bedroom as cues for sleep and weaken them as cues for arousal and to develop a consistent sleep-wake schedule to improve the quality and quantity of sleep. I would like to quote an example here. Like insomnia patients are asked to get out of the bed and only return when they become sleepy again.
Okay. And what is the sleep restriction therapy?
This is a therapy that does not basically aims to restrict the actual sleep time, but rather to initially restrict the time spent in bed.
That is very informative, Dr. Vajiha.
Okay, Akif, I would like, I guess our audience would be interested in knowing the medications which can treat the insomnia. So Akif, please, can you give us a review of medications that is used for treatment of insomnia?
Sure, Dr. Vajiha. We have certain medications that are approved by the FDA, US FDA for treatment of insomnia. We have drug classes like benzodiazepine receptor agonists that include the drugs like zolpidem, zolpidem, alprazolam, and bromazepam, etc. Then we have melatonin receptor agonists. These include the drugs like melatonin and remiltion. Then we have orexin antagonists. So these include the drugs like Sorexent. So all of these are used for treatment of insomnia.
That's interesting. I guess everyone would like to know that what is the mechanism of action of these drugs?
Yes. So all the drugs used for insomnia produce their effect either by increasing the sleep promoting neurotransmitters in the brain or inhibiting the wakefulness promoting neurotransmitters in the brain.
Mhm. So what is the concept of sleep promoting neurotransmitters?
So, sleep promoting neurotransmitters, these are the chemicals in the brain that promote and maintain the sleep state of the body.
Mhm.
The common neurotransmitters that are associated with this sleep, these are like GABA, gelanin, adenosine, melatonin. These all are sleep promoting neurotransmitters.
Okay, that's interesting. And what about the alertness promoting neurotransmitters?
So these neurotransmitters, they maintain or they cause the alertness state of the body. And we have neurotransmitters like histamine, orexin, serotonin, dopamine. They all are alertness promoting neurotransmitters. So they actually like maintain the wakefulness state of the body.
Okay, that's interesting. Okay, so Akif, whenever anyone takes any medications, they are very much interested in the side effects. So can you elaborate a bit about the side effects of these medications?
Yes, let me tell our audience that the common side effects that are associated with these medications, these include the rebound insomnia, which is a sleep disturbance or recurrence of the insomnia while we discontinue the medications abruptly. Then we have somnolence, which is the state of being sleepy or ready to fall asleep, or drowsiness. Then we have residual sedation, amnesia, impaired psychomotor functions as well.
Okay, that's very interesting. So thank you everyone for your attention. Together we can make a difference in the lives of those struggling with insomnia, helping them achieve the restful nights and healthier days they deserve.
Excellent.
Thank you, everyone. If anyone has any queries, please do not hesitate to contact us at the email texas123sleep@gmail.com.
Thank you.
Dr. Vijay and Akif, excellent presentation. Loved it. Very good. We had a
Thank you,
couple of
sir.
questions, and one of the questions I'm gonna put up to you guys was earlier from Bilal, and I promised to answer this question. And that was about the role of diazepam and insomnia, and the fact that he's using it. So let me go out by saying a couple of things about reinforce what Akif and Wajia said, and diazepam. Non-benzos are preferred. Okay, don't take benzodiazepine or benzos for your insomnia. It's not good, Bilal. Okay, so why? Because benzos are addictive. They are very addictive, hard to get off them. Side effects: residual sleep, residual sleep, and rebound effects. Absolutely what Akif has sort of pointed out. So you need to try to get off them. And then that means the second thing. Have you tried CBTs therapy, which is non-pharmacological therapy? Very critical. Tip number 3, you maintain good sleep pattern and look at your sleep hygiene. And one of the things another question that came up was caffeine intake. Do not think that tea is benign. So anything that affects your adenosine receptors, coffee in general, monster drinks are horrible. And a lot of people who have insomnia have been on these monster stimulants and drinks. And if you are not sleeping well, you have to look at your caffeine intake and eradicate that from your body. So we'll discuss this in the tips part of question. And that's why what Vijaya was saying is very important, is that you have to look at the history and you have to look at what are the factors that are maintained. And I have a lot of questions about people saying in this, I'm not sleeping well. I'm not sleeping well. What should I do? Give me some advice. We'll have to look at this a little bit more in the tips and combine it with insomnia in the latter part of the presentation. But the essence is that you cannot go on to medications without a proper follow-up. They're very addictive and they affect you. Number 2, if you have insomnia, you should consider getting a sleep study to make sure you are not snoring, you're breathing, and don't have restless leg, and you don't have seizures, and you don't have any other disorders. Very important to screen, something that we're going to discuss in the case studies. I'm just going to move on because I just want to touch on those. And other little question is, generally, there are no medications for sleep apnea. If you are snoring and you are fatigued, there are no direct medications to fix this, except for medications to give to reduce your weight. And even then, it doesn't fix all of your issues. So the neck size matters. What is the tissue around your thing? And like the video, if you go back and see it, you get obstruction at the back of your throat and you're dropping your oxygen. And that cyclic drop of oxygen is what activates the sympathetic system, is very detrimental. So let me just move on to that. That was so brilliant question. I'll just take 1 or 2 questions from the audience. I think we got another question from Mirza. We'll take his question.
Thank you, sir. I want to know how much time it takes to become addictive to benzodiazepines of different rates.
Akif, do you want to answer that question? How long does it take to become addicted to a benzo?
So generally, some literature suggests that I think up to 5 to 6 months of taking benzodiazepines, they develop tolerability and addiction.
Yeah, I think your addiction level starts building up once you reach that level and it starts striking. So I would put that as it's actually even earlier than that. The fact that what Akif is saying is when you will have bad withdrawal effects when you go into more than 3 months of uses of the medication. You should not be using, you can use a benzo for a short term, But after that, like what Vijaya was saying, if it's an acute insomnia, you don't want it to translate to a chronic phenomena. It can be transient, for example, after a death, after a stress, after an event, but you don't want that transient or acute insomnia to linger on to be a chronic insomnia. And that's where the issues start becoming. Once you become a chronic insomniac and you are sleeping less than the defined sort of 6-7 hours, you have problems. Someone else said saying, oh, I'm 24 and I'm okay to sleep less. I said, you are not okay to sleep less. You absolutely need more sleep. And especially in kids, which was going to be the next topic, you need to make sure the kid is sleeping that 10 hours or 12 hours, depending on the age. Newborns sleep even longer. Up to 3 years, you should be sleeping over 10 hours. So, like we said, duration matters, and then the quality matters of the sleep. So, we got to factor both of those in. I'll take one more question. We have Heather there, and then we'll move on to the next presentation. Heather? Heather
Hello
Abbas.
everyone.
Hello.
First, I would like to thank and congratulate Dr. Khan and his brilliant team for this brilliant seminar. It has been really informative for us. My question is that we have heard quite enough that we have to have a blue light filter on whenever we use mobile or our devices. I never really understood why it was a bad thing. And as a follow-up, I have noticed that whenever I use my phone too much at night, my eyes feel irritated even when I close them, and the pictures plays behind them. Does that have to do with the blue light?
Vijaya? Dr.
Yes, sir.
Vijaya? Uh-huh.
Yes.
Blue light.
Okay, so there is a hormone that is called as melatonin that usually suppresses, makes us feel drowsy, which also promotes wakefulness during the day. So when we use the blue light, it suppresses the melatonin and makes it hard to let us sleep at night. So that's why we should avoid blue light and keep the blue light filter on our phones and avoid to use phones when you are trying to sleep at night.
Yeah, light matters. Melatonin affects the circadian rhythm, is what Vijaya is saying. And circadian rhythm is very important to keep your sleep cycle in order. So darkness brings the melatonin level up. Bright light removes the melatonin from your system. The melatonin is in your brain, and it's a powerful stimulant for sleep. So don't lose that. Don't lose the powerful stimulant. We'll take just one more question from Naman and then move on if he's available. Let's see if we can unmute Naman, and otherwise we can move on. Okay, not available. Let's move on. Excellent. So our next presentation is going to be the role of sleep in kids. So we want to try to see if we can bring some awareness for sleep and kids. And for this presentation, we have Brenda Weirick and Mary Lee Bukowski. Both of them worked with Pulmonx and Texas Sleep. Brenda and Mary Lee, you've got the stage, girls. Brenda, you need to unmute yourself.
Okay, can you hear me now?
Yes,
All right.
ma'am.
Hi, this
Please.
is Brenda Wyrick. I'm one of the nurse practitioners here at Pulmonx Plus. I kind of oversee the sleep lab, and I'm here with Mary Lee, my coworker.
Hello, my name is Mary Lee Bukowski. I'm also one of the nurse practitioners here at Pulmonx Plus, and we are delighted today to present to you about sleep apnea in pediatrics children. And during this presentation, we will tackle about the definition, describe the common clinical manifestation, identify the risk factors, and discuss a little bit about the treatment options.
Okay, so today we're going to be discussing the effects of apnea in children. We're going to focus our talk today on children.
Mary Lee, can you share the presentation, please?
Yes, let me.
So keep talking, Brenda, that's fine.
We're going to focus our talk today on children 3 years of age and older. Sleep apnea is a disorder in a child's breathing that causes partial or complete blockage of the airway, causing awakening in their sleep and their normal sleep cycle.
So how do we know if a child has a possible sleep apnea? What are the signs and symptoms?
So signs and symptoms can include anything from snoring. It can be an indicator of their sleep apnea, and there's also secondary to an occlusion of their airway. They can have bedwetting that continues past the toddler years, daytime sleepiness, needing more frequent naps, behavior issues, hyperactivity that can also be a symptom. And then there's growth and development can be affected with signs of cognitive or intellectual delay noted by poor performance in school. And then enlarged tonsils and adenoids is one of the main causes for pediatric sleep apnea. Do we have the slide?
Can you see our slide?
You're not shared. Let's do this. Oh, I told you not to do that. What happened? Don't do that. I don't want you to do anything. It's frozen. So let's do this. I think we're having just a little bit of an issue with Brenda, Mary Lee slides, which we're not able to share right now. We'll move on to the next one and then come back to your presentation when Mary Lee is ready again. Let's move on to discuss restless leg first. And we can discuss restless leg. We'll have, let's have Dr. Jannah Malik and Ryan Brewer to be discussing restless leg. Jannah?
Thank you for that introduction, Dr. Khan. Hello, everyone, and thank you for joining us today. My name is Ryan Brewer, and I'm the Sleep Lab Supervisor here at Pulmonx Plus. Today, I'll be co-hosting with Dr. Janet, who will be discussing restless leg syndrome. Welcome, Dr. Janet.
Thank you, Ryan. Thank you for having me. Ryan, can you share the slides because I'm also not able to share the screen? I'm able to share now. So do you want to keep sharing yourself?
Keep going, please.
Okay, so my name is Dr. Jannat Pervez Malik, and I am a medical graduate from Pakistan. I graduated from Rai Medical College, Sardoda, and after that, I have been working as a virtual sleep liaison for Pulmonx Plus. I am very excited to be here and today discuss this very important topic.
I'm excited as well. So today we are here to discuss a very important sleep disorder that many people are not aware of, and it is called restless leg syndrome. So can you explain to the audience and I what exactly is restless leg syndrome?
Yes, Ryan. So, restless leg syndrome is a neurological disorder in which there are constant unpleasant sensations in the leg. And this is accompanied by an irresistible urge to move the legs. Some people describe it as a burning sensation, some would describe it as a crawling sensation, some describe it as having pain in their legs, and some would say that it is an aching sensation. And this is usually reported by the bed partner of the patient that has restless legs. And this condition could be so severe that the patients are unable to sleep at night. And even if they sleep, it can cause the patients to wake up again and again. And this can lead to unrestful sleep.
All right. And do you have a video so the audience and I can see what RLS might look like?
Yes, so this is the video of a patient. He is sleeping, and we can see that he is continuously moving his legs. And we can see that these are the twitching movements. So this is how severe restless legs could look like in sleep.
Okay, that looks pretty severe.
Yeah.
So this seems like to be a really bad condition to have as it disrupts sleep, and good sleep is crucial to the overall well-being of a person. So Dr. Janet, I have seen my partner moving their legs before. Does this mean they have RLS?
No, Ryan, not every urge to move the legs are restless legs. So there's a specific criteria that has been laid down to diagnose the restless legs. So the first one is that there must be an urge to move the legs. The second is that these symptoms should be present exclusively or they should become worse in the nighttime. The third criteria is that these symptoms begin or they are worsened during periods of rest or inactivity. And the fourth is that these symptoms are relieved transiently by movement or stretching. And the fourth thing we need to be aware of that they should not be present due to any secondary medical condition. So RLS is a purely clinical diagnosis, and it is usually diagnosed when the patients go to their provider with their symptoms.
Okay, and I understand this is something your doctors diagnosed based on your symptoms. Does a
Yeah.
sleep study give any information regarding the diagnosis of RLS?
No, Ryan. So as we have discussed that RLS is a clinical diagnosis, and what we do, what information we can get from a sleep study are the periodic limb movements. So what are the PLMs or the periodic limb movements? These are withdrawal movements in one or more legs, which are only recorded during the sleep study. So these occur at an interval of 20 to 40 seconds during sleep, and they may be present inconsistently, which means that they need not to be present on every sleep study. So this is a picture. We can see that this is how the PLMs look like on a sleep study. Actually, 90% of the patients that have RLS, they do show periodic limb movements on their sleep studies, but it is not, yeah.
Okay, thank you for that. And I think our audience would understand this better if we knew what are the causes of RLS and why does it occur.
Yes, Ryan. So a very important cause of RLS is the iron deficiency anemia. And people with conditions that have that can cause low iron, they are more likely to develop RLS. So this can include the people, the women who have heavy menstrual cycles, people with certain bleeding disorders, people with certain malabsorption syndromes such as the celiac disease or the irritable bowel syndrome. It can cause a hindrance in the absorption of iron in their blood and thus leading to development of the symptoms of RLS. Another very important condition is the pregnancy. So, certain changes in the body that occur in the pregnancy, such as the increased blood volume and hormonal changes, they can contribute to symptoms of RLS. And these mostly occur in the third trimester and they usually resolve with the delivery of the baby. Other important causes could be genetics, and there are also certain medications such as the anti-nausea drugs, the antipsychotics, and certain antidepressants. They can also cause RLS. And one very important thing that we have already discussed is the obstructive sleep apnea. Sometimes patients that have OSA, they can also have RLS.
Okay, and I see you've mentioned iron deficiency as a top cause. Can you kind of explain to us how iron deficiency causes RLS?
Yes, so dopamine is a neurotransmitter in the brain, and it is very important in controlling the muscle movement. And iron, as we have already discussed, it is very important for the formation of dopamine. So if we have a deficiency of iron, it causes an imbalance of dopamine in certain regions of the brain, and this can contribute to the symptoms of RLS.
All right, so if someone in our audience suspects they have RLS, what kind of tests might be useful for them to know?
The first thing for anyone to do who suspects that they have RLS, this could be, can we go on to the next slide? This could be that they need to get their iron levels checked. So the specific diagnostics test that is used to check the levels of the stores of iron in our body, that is the serum ferritin level. So the specific test we need to go for is the serum ferritin level, and a simple CBC that could show normal levels of hemoglobin in our blood, but you might have an underlying iron deficiency. So we need to go for the serum ferritin level first. And the other thing we can do is the lifestyle modifications. So the first thing we can consider is the sleep hygiene, and we need to engage in moderate physical activity. If you suffer from insomnia, then we need to get help for chronic insomnia. We need to avoid the medications such as anti-nausea drugs, antidepressants that could trigger the RLS. And we need to identify and get treatment for OSA, because sometimes treating the OSA independently can resolve the symptoms of RLS.
All right, thank you for that, Janet. And if someone is diagnosed, they should definitely seek treatment. So what can they do to help this condition?
I think before talking to your doctor, some things we could consider are the massages and warm baths, and because these also help alleviate the symptoms temporarily. And we can also consider hot and cold packs, and there are certain pneumatic compression devices available out there in the market. We can also consider that, and since caffeine, alcohol, and nicotine could trigger RLS, so we need to limit their intake.
Okay, thank you, Dr. Janet, for these insights. And thank you, everyone, for listening to our important message about RLS. Again, if you have any questions, please reach out. Thank you for your time today.
Thank you, Dr. Jenna, and thank you, Ryan, for that presentation. That was very good. I think it answers quite a few questions people have. One of the questions that came up, well, let me take a question from the audience and see if we can get Sadia. Sadia has a question. We can see if we can answer her question. Sadia or Abdullah?
Hello, Assalamu alaikum to Dr. Khan and all the esteemed panel of doctors out there.
Hi, Abdullah.
Before asking any questions, I really want to thank you, Dr. Khan, and the wonderful panel of doctors out there for hosting this informative webinar on sleep. And the insights and knowledge shared in this presentation is incredibly valuable and appreciated.
Thank you.
But I have a question, and well, I want to know that are there any sorts of medicines that can help with restless leg syndrome? And are they easily available, or do I need to get a prescription? Or are there any home remedies that can work better for this?
Dr. Jannah?
Yes, so the first thing we can consider are the home remedies that we have discussed. And if we do have very severe RLS, then there are certain medications that are there. And these include the dopamine agonist, but these medications also have a lot of side effects, and they are only available on prescription. So the first thing we recommend that is that you engage in moderate physical activity so that you could alleviate some of these symptoms. And then if still not resolved, then I think you can go for medications.
Very good. Next question I'll take in. If Sadia is available, she can ask her question if she can unmute. Otherwise, and if she's available, if not, then the question that I have one is that I have my partner kick a lot in the bed. Could this be restless leg, Ryan? My partner is kicking. This is saying he's doing it a lot. Could this be restless leg?
Not necessarily, but he would definitely want to look into other symptoms to be diagnosed for the restless leg. Doesn't mean that it's restless leg, but something it could be.
Very good. And so it could be sleep apnea. And if it's not that, then they needs to see what the iron, specifically what Dr. Jannah has mentioned, the iron levels, not necessarily the hemoglobin, but the iron levels is something that and your iron levels need to be above, generally 70 is the threshold. So you should ask for that. The other question that has come up is, can kids have restless leg? Dr. Jannah.
Yes, sometimes there are certain kids who are autistic and they are quite restless and fidgety. So their parents could think that they have RLS, but in fact, this is just restlessness. But we do have restless legs in kids also.
Brilliant. Well, let's keep moving, and we're gonna move on to our presentation with the kids in this time now again. And I think in the studio, Jeremy has the slides. He's gonna share them. I'm gonna request Dr. Brenda Werick and Marilee Bukowski to come back and do their presentation. All right, Brenda, we're gonna be running this from the studio. Okay, girls, you can start.
Thank you so much, Dr. Khan, for that introduction. I'm Marilee Bukowski. I'm one of the nurse practitioners here at Pulmonx Plus, and with me is Brenda Wyrick.
So see if Brenda is unmuted. So Brenda is going to be
Brenda. Yeah, there you go. She's right.
I just lost everything.
No, you're here. We have you.
So again,
Marilee, you just keep going, and Brenda will join if she can.
Yes, this presentation will actually focus on sleep apnea with a pediatric population, and we're going to tackle about the definition, the common clinical manifestations, and identify the risk factors and how to diagnose sleep apnea in kids. And at the end will be the treatment options. So, Brenda, can you hear me?
Yeah, now I can.
Okay, so could you tell us more about sleep apnea in children?
Okay, so yeah, we're going to be discussing the effects of sleep apnea in children. We're going to focus our talk today on children 3 years of age and older. Sleep apnea is a disorder in kids' breathing that causes partial or complete blockage of the airway, causing awakenings in their sleep or disruptions in their normal sleep cycle.
Yes, that's true. Actually, sleep apnea in kids is estimated to affect 1 to 4% of children of all ages, and if left untreated, could lead to complications like growth and developmental challenges. So, what are the clinical signs and symptoms of sleep apnea in kids?
Okay, so kids can have snoring. This can be an indication of sleep apnea, and also that there may be an occlusion of their upper airway. And then there could be bedwetting that cause past their toddler years, daytime sleepiness, needing more frequent naps, behavior issues, hyperactivity can also be a symptom. And then changes or delays in growth and development with signs of cognitive or intellectual delay. Causing poor performance in school. And then enlarged tonsils and adenoids is one of the main causes for pediatric sleep apnea.
So how are the size of the tonsils and adenoids affects, or can cause sleep apnea?
Well, so speaking on the tonsils and adenoids, children with significant enlargement of their tonsils can increase their risk of apnea due to occlusion of the upper airway. As we see in the picture, we can see the progression of the size of the tonsils and the occlusion that can occur when the tonsils enlarged. So like in picture 0, there's like, you can see full of the oral pharynx, whereas in 4, there's full occlusion. And this can also cause snoring. And then here we have the Malapati score, a score used for the evaluation and visualization of the posterior pharynx. In class 1, you can see the full oral pharynx, whereas in class 4, you have full occlusion. And then when you have enlarged tonsils as well, you can have a lot of obstruction of the airway and sleep apnea.
So other than the adenoid size and the Malapati score, what are the other causes of sleep apnea?
So obesity is another big cause. And as we know, obesity is on the rise in children here in the US and I think globally. So with this, there's an increase in sleep apnea, and we can also get hypoventilation syndrome, which can cause increases in their carbon dioxide levels, resulting in hypercapnia. So we always check for hypercapnia when we test children for sleep apnea.
That's true. Actually, although OHS is rare in children, but it can lead to serious complications. And in fact, up to 20% of these obese children may have OHS. So we'll proceed to the genetic disorders that can cause sleep apnea. Could you please elaborate them, Brenda?
Yeah, so there's several different genetic disorders or different disorders that can cause sleep apnea in children. The main one is Down syndrome. It has a high prevalence of sleep apnea due to the presence of many risk factors that contribute to airway obstruction, like their anatomic abnormalities of the enlarged tongue, tonsils, mid-face hypoplasia, and other associated conditions like obesity, hypothyroidism, hypotonia, and gastroesophageal reflux. Marfan syndrome has a 30 to 40% increased risk of sleep apnea, mostly due to their head and facial abnormalities. And then they also have a floppy airway tissue that can increase their risk. And autism spectrum disorders can have up to a 96% increase as well. There's a presence of a combination of sleep apnea as well with them, with the range of symptoms, including the loud snoring, excessive daytime sleepiness, and changes in cognitive function. These can have an overlap and delay diagnosis in kids. And then seizure disorders can often present in sleep, often worse in REM sleep. And the full seizure montage needs to be assessed with children with sleep apnea.
Thank you, Brenda. I think there are also medications that can potentially impact sleep and breathing in pediatric patients. What are these medications, and how can they affect, children?
Medications of all types can affect sleep by making a child more hypersomnolent or cause more sleep-wake disorders. When children are on these medications, they should be reviewed if they have any sleep disorders. It's crucial for healthcare providers to carefully consider the potential impact of medications on sleep and breathing in pediatric patients, especially those known to have sleep apnea. Monitoring for changes in sleep patterns, respiratory function, and overall symptomatology is essential when medications are prescribed.
I think indeed that's true. I agree that as a healthcare provider, it is important for us to review the medication list of our patients and overall, especially the kids, before prescribing this medication. Next slide, please. Okay, so now I'm wondering, how do we perform a sleep study in children? Is it the same as how we perform it in the adults?
Yeah, child sleep study and monitoring is much like that of an adult, except that we do the end-tidal CO2 monitoring as well to assess for hypercapnia. There will be EEG leads on the head monitoring brain waves and stages of sleep. These leads will let us know if the child is awake or asleep, and then the different stages of sleep. and if there's any seizure disorders. The cannula at the nose can measure the end-tidal CO2 and nasal airflow. There'll be leads at the eyes that allows for monitoring the stages of wake, sleep, and REM sleep. EKG leads to monitor heart rate and rhythm, respiratory parameters, including airflow, respiratory effort, oxygen desaturation or saturation is identified, and issues such as so we can identify issues like obstructive sleep apnea, central apnea, and hypoventilation, respiratory measures. We have belts around the abdomen and the chest and a cannula at the nose and mouth to help measure airflow. And then there will be leads on the legs for monitoring for movement of the muscles and the legs and for periodic limb movement disorder. A microphone at the throat that's going to measure snoring. And then there's always a camera in the room to monitor the child while sleeping and monitoring for abnormal activity, talking, and other parasomnias.
I see. Interesting. So once the sleep study is performed, how then we diagnose the sleep apnea in kids?
Okay, so the gold standard for diagnosis of sleep apnea in children is the PSG, which is the in-house overnight sleep study. The diagnosis in children is based on the apnea-hypopnea index identified on the PSG, and this indicates whether there's an abnormal number of respiratory events occurring per hour of sleep. So in children, just having one apnea-hypopnea per hour is considered positive for sleep apnea. So children with snoring or disordered breathing, as well as behavioral or learning disabilities, should be screened for sleep apnea. And then have the sleep study to watch for obstructive and central and mixed apneas. And then we also want to monitor CO2 levels, and any CO2 level greater than 50, along with snoring and disordered breathing, is considered positive for sleep apnea.
Thank you. I think it's also important to take note that the use of home sleep apnea test is not recommended for the diagnosis of obstructive sleep apnea in children. Why? Because there are, insufficient evidences. There were really no literature showing that this home sleep study device can monitor carbon dioxide and as well as the ability to identify arousal, which is the measurements that have been viewed as critical in pediatric population. So, okay, we confirmed the diagnosis now. What are the treatment options that should be, discussed with the patients and especially with the parents of these kids?
Okay, treatment options for sleep apnea, typically for kids, is removal of the tonsils and the adenoids, along with weight normalization, is considered the first line of therapy for children and adolescents. Children who had surgery and that are obese will need to have a follow-up sleep study later to see if the removal of the tonsils and adenoids was enough to treat the sleep apnea. Otherwise, they may need a PAP therapy. Other treatments could be tongue reduction and tracheostomy, and these are used for more life-threatening or obstructive apneas that are not completely treated with PAP therapy and other treatments. And then oftentimes just removing the tonsils and adenoids will improve the snoring and the sleep apnea in kids. And studies have shown that post surgery, they have improvement in intellectual delay in school-age children.
Thank you for that, Brenda. So I think the important message here in this presentation is that we should be keen as providers that those children with loud nightly snoring, fragmented sleep, and behavioral issues should be always screened for obstructive sleep apnea. Additionally, all children with a potential diagnosis of ADHD should be actually asked about sleep quality and duration before considering starting medication. And early recognition of symptoms can improve academic performance and long-term outcomes for these patients. And again, thank you so much for listening today. Here are references. And Brenda?
Yeah, thank you for allowing us to talk to you today about the importance of pediatric sleep apnea. And if you have any questions, please contact the link provided.
Excellent. Thank you, Brenda, and thank you, Mary Lee. That was a very good presentation. Appreciate that. Let's try to see if we can take a few questions. We have one from Noman. See if we can get Noman on. If Noman is not available, there is one question about from my kid does not sleep and is very restless during the night. But what I'm worried is that she snores a lot. Sorry, she snores a lot. What should I do? Mary Lee?
Thank you for that question. I think it's everybody's concern when you have a kid, you're always worried what's going on. So I think the best thing to do is it depends on how old are they. Okay, if the kid, usually in our clinic, we see a minimum of 3-year-old kid and up. Of course, that's until less than 18 years old. So you can contact your primary care doctor, have an initial evaluation, and get a referral to go for a sleep study evaluation. And again, the sleep study, it should be done in the lab. So it's always important that the caregiver or the parent or make the environment in the lab as close as to your child's bedroom, so we can get an ample amount of data that we need during the sleep study.
I just want to add one point to this. If your kid does not sleep well, they're not going to grow. They will be behind other people. Plus, the growth is impaired because the growth hormones and the other hormones are not going to secrete properly. And then the second issue, if they do not sleep cognitively, intelligence-wise, they will be behind other people. So having this looked at, if your kid is snoring and you are not addressing it, the parents are liable for the kids' issues. So just keep that in mind. And the other thing that Brenda pointed out is that if they are obese, I know we like our kids very chubby and we like our kid, the goal mole, it's like Vajia saying, let's do the next session in Urdu. So we're going to finish this session, but then take on more questions if you like in Urdu, and we'd be happy to answer them. But that's going to be the next session. But if your kid is goal mole, which is fine, they need to be a little bit goal mole, but they should not be snoring and they should not be waking up with issues. So I've had a question about I'm waking up with sleep tremors and sleep paralysis. So a relevant little question, what if you have sleep tremors and what these are parasomnias? Parasomnias are exacerbated by a couple of things. You have to make sure that there's no seizures, which is less likely. But the important thing is you got to make sure there is no obstruction at the back of the throat. And that may cause an issue with a lot of people. So like I said, that's very relevant. The kids' sleep is actually what made the sleep flourish a lot in the US, because your future kids and generations are affected. So just keep that in mind. Okay, we're just going to pause there a few minutes. We're going to take a 5-minute break. And when we come back, we're going to do the next session on the case study and stuff. And the next case study session is going to be done in primarily English, but also in Urdu. So just a few minutes break, and then we're going to get back into it so we can finish the rest of the presentation. So far, thank you very much, everyone. Okay. That's okay. Leave it. Leave it. Okay, hello. So, hello and welcome back, everyone. I hope you can hear me now. We're going to go back and do the next session in English and some in Urdu. So, किसी का भी कोई question है, please अपने आप question जो है वो खुल्लम खुल्ला बताएं हमें. हम इस सेशन का मकसद ये है कि आपके सवालों का जवाब दिया जाए और आपके क्वेश्चंस को आंसर किया जाए. So all of you, any of you who have a question, just let us know. Let me start off with the first question. Can stimulants help sleep apnea? Why they not cause muscle spasm and worsens the airway? Can stimulants help? Sophia, could you answer the question, please? Sophia and Fatima.
Well, sir, CNS stimulants, they can be used to promote daytime wakefulness in sleep apnea patients that can have, the daytime sleepiness but the actual treatment still remain to be the BAP therapy.
Okay. All right. Next question here. Dr. Vijaya explained about different type of insomnia. So what is the treatment if you have acute insomnia? Do we need to change the lifestyle with or without medication? And what would help? Vijaya and Akif. Insomnia hai. Insomnia ki treatment, acute insomnia ki treatment kya hai?
So actually, acute insomnia occurs for a very short period of time. And it is also depends on the life circumstances. Like अगर किसी को कोई anxiety है, कोई papers हैं, students में, तो उनमें insomnia normal बात है. Then after that, if insomnia doesn't cure on itself, then we have to consider it to be the chronic insomnia, और वो भी उसकी time period है कि वो long हो. Then we have the medications, and Akif, you can tell us about the medications.
So just you can use, I don't know if Akif is there, he's not here hearing. देखें basically ये है कि insomnia जो है ना वो अगर short term है और transient है, insomnia होना is not wrong. आप किसी भी worry से रात को उठ जाते हैं, कोई परेशानी है, it's normal to have emotions drive your sleep. Prime example, last night I didn't sleep well because I was worried that I may not get up. So if you classify, did I get my sleep? Did I get my 7 hour, 6 hour, 7 hour sleep? I didn't. So broadly, it's like I was up and if I wake up and I'm not fresh in the morning, then there is an issue. But if I keep on doing this every night, every day, तो मेरे दिमाग का जो process है ना वो खराब होना शुरू हो गया. About sleep, मुझे sleep का जो concept यही होना चाहिए कि आप bed देखो और आपको नींद आना शुरू हो जाए और आप bedroom में जाओ और आप वो चीजें ना करो जो वहां पे जो नहीं करने वाली और वो करो जो करने वाली है. Okay,
yes,
so that is
basically on
important.
CBT. Yes.
Exactly.
This is basically CBT.
This is CBT. और इसी से जब हम इसको ट्रीट करते हैं तो हम वो चीजें reinforce करते हैं जो आपको बेडरूम में करनी चाहिए. फॉर एग्जाम्पल, प्राइम एग्जाम्पल है सबके लिए, कितने लोग अपना फोन बेडरूम में लेके जाते हैं? Let me ask you, the question is, how many people take their phone in the bedroom? Or the question really is, how many of you don't take their phone? Let me find a few of those brave people.
I guess that percentage will be very low.
I know. So technically, if you speak, I'd say a person who's changed his perception about sleep, अपना phone bedroom में नहीं लेके जाएगा. The day you would do that is that you'll prioritize your sleep, you prioritize your life, and turn it off. कुछ नहीं होने वाला आपका. On रखो, off रखो, mute करो ना. आप phone को बाहर रख दो और कुछ भी नहीं होगा. दुनिया नहीं चेंज होगी, प्रेसिडेंट नहीं चेंज होगा, इमरान खान नहीं आएगा वापस पॉलिटिक्स से इतनी टाइम में रातों रात. आई एम टेलिंग यू गाइस फॉर श्योर. और ट्रंप भी जिंदा रहेगा, सारी दुनिया वैसी की वैसी है. So it's not going to change. Nothing is going to change. Everything is going to be the same. Nothing, no scenario is going to change. The key message is, and actually a very big point, computers, laptops, and the biggest culprit is the phone, has changed our sleeping ideas and patterns. You know, someone told me it's very interesting fact. Humans are the only species who decrease the duration of the sleep. It's the only, no animal does that except for humans. And we think that we are doing good by doing that. And actually we're not. So if I find someone, you're going to direct message me and tell me, I was Dr. Khan before you told me I'm not taking my phone in the bedroom and I'm good. I'll give them a prize, a separate prize. But in essence, in real essence, you should be doing that. And I can guarantee you'll live longer and you'll be happier and you'll be less with problems of insomnia and stuff. So we'll discuss that. So that was a very good question. I just wanted to reiterate that. Let me take a few ek do aur questions about this. Can gabapentin cause insomnia in long term? Gabapentin generally promotes sleep. Okay. So in the long term, it should not. It promotes sleep, or usko ye nahi karna chahiye. So that's, I just want to knock off that question. One of the question I do want to get from the panel, and probably from Brenda and the others. My daughter has had adenoid and tonsillectomy at the age of 9. She had congenital sleep apnea. And she had adenoids. She was cured. She was doing pretty well. She was the best student. But now at 15, age 15, this is about 6 years afterwards, 6 saal ke baad, she is sleeping sitting up and is much shorter in height from her peers, and the x-ray shows a right sinus enlargement. What are the treatment options, if any? And there's no snoring, but she still has problems sleeping soundly, laying straight, flat. Brenda, what do you think? Adenoids, but she has a sinus problem.
Well, I think, working on the sinus issues, but I think she should be tested for sleep apnea, because sometimes, especially if she had congenital sleep apnea, or she probably likely may still have some occlusions going on that are more in the throat airway. And so she should get that checked, and then the sinuses as well.
Yeah, I think I agree with it. The patient flat hote bachcha nahi so raha. So jab aapke sinuses, they drip back, they can obstruct. Generally they can obstruct. So kya hai ki jab sinus drain, jab aap lete hai na, it starts draining backwards, and the fluid can go into it. So you have to fix your sinuses from the get-go. That's the first thing. If the kid is sleeping up, then that means when she or he is going flat, uska airway collapse kar raha hai. सारा इशू ये है कि आपका एयरवे कोलैप्स नहीं करना चाहिए, आपका बैक एयरवे को इशू नहीं होना चाहिए, इसीलिए हम एयरवे प्रेशर देते हैं. और contrary to what people think, and I know a lot of people are saying कि नहीं मैंने ये नहीं लगाना, CPAP नहीं लगाना. अगर आप राइट कैंडिडेट है, आपकी लाइफ चेंज हो जाएगी CPAP लगाने से. और ये सिर्फ ये नहीं है कि आप मोटे हैं तो आपको लगाना पड़ेगा. एक्चुअली आप पतले भी हैं लेकिन आपका एयरवे फंसा हुआ है पीछे और ठीक नहीं है, then you can have issues. So please मैं आपको दोबारा take home message इसका है कि kids को नहीं, don't ignore the kids issues को address करना है, number 1. Number 2, अगर आप fresh नहीं उठ रहे तो आपको sleep का issue resolve करना चाहिए, देखना चाहिए. Mirza wants to ask another question, so I'll in the interim, I've got a few other questions that I want to answer before we go on to Mirza. Do you want to ask your question?
Thank you, brother, for the brilliant and superb presentation. I should say that.
Thank you.
There are some patients who are taking Lexotanil for last 3 years, Ativan for last so many years. What can we do for them? Because whenever
एक Ativan ले रहे हैं, दूसरा कौन सी?
Ativan and Lexotanil.
Lexotanil. What's a Lexotanil group?
Lexotanil is benzodiazepine.
Benzodiazepine सालों से ले रहे हैं. कितने सालों से ले रहे हैं?
1 for 3 years, 1 for 7 years.
देखिए मेरी बात सुने. Ativan किस लिए है मेडिकेशन?
बेसिकली तो रिलैक्सेंट ही है ना ये.
रिलैक्सेंट है, एंजाइटी के लिए है. क्लासिक इंडिकेशन एंजाइटी के लिए है और आपको कामिंग मेडिकेशन करने के लिए है ये. सो अंडरलाइंग इश्यू कोई चल रहा है. सो ये नंबर बात रखना. जितनी देर आप बेंजोस पे फंस जाते हैं ना, उतना मुश्किल हो जाता है आपको उतारने के लिए. सो सबसे पहले जो है ना, आपको वेकअप से लेके स्लीप तक के लिए अपने फैक्टर्स देखने पड़ते हैं कि आपको इश्यू कहां से चल रहा है. कि आपका सबसे पहला टाइम स्लीप वेक टाइम क्या है. डे टाइम में आप कैफीन कितनी ले रहे हैं, कॉफी ले रहे हैं या नहीं, कॉफी अवॉइड करनी चाहिए, चाय को अवॉइड करना चाहिए अगर आपको इंसोम्निया इशू है. और मैं कॉमन ये देखता हूँ, कंप्लेंट मुझे मिलती है कि वो कहते हैं यार सुबह मैं ले लेता हूँ, शाम को मैं लेता हूँ, मैं तो रात को सोने से पहले भी ले लेता हूँ. भाई आप सोने से पहले जरूर पी सकते हैं, पर ये याद रखें कि आपके एडेनोसिन लेवल नीचे जाते हैं और ओवर पीरियड ऑफ टाइम एज के साथ साथ आपके एडेनोसिन लेवल बिल्कुल नीचे चले जाएंगे और आपको नींद नहीं आएगी, या आप बैक एंड पे जल्दी उठ जाएंगे और सुबह उठ के जो सब लोगों से पहले उठ जाएंगे और तैयार हो जाएंगे कि मैं काम के लिए तैयार हूं. भाईजान सुबह उठना इज अ गुड हैबिट, पर तब है कि जब आपने नाइट की स्लीप कर ली हो. वैसे उठ जाना सुबह के लिए इज नॉट अ गुड हैबिट अगर आपकी नींद नहीं पूरी हुई. सो आई जस्ट वांट टू से दैट. सो इंटीमेटली जब आप ये बेंजोज ले रहे हैं और दूसरे एंटी एंजाइटी मेडिकेशंस ले लगे हुए हैं, तो एक तो सबसे बड़ा फैक्टर जो प्रॉब्लम आ रहा है ना, जो दूसरा कॉमन मैं देख रहा हूं, हमारा स्ट्रेस रिलीविंग मैकेनिज्म कोई नहीं है. योगा का हमें पता कोई नहीं है, हमारे अंदर एग्जिस्ट ही नहीं करता. एक्सरसाइज करने की हमें आदत नहीं है. टीवी हम देखते हैं तो, या बुक पढ़ने की आदत लोगों को बिल्कुल ही नहीं रही. सो स्ट्रेस रिलीविंग मैकेनिज्म, तो जो हमारे पास पॉइंटर्स हैं स्ट्रेस रिलीव करने के लिए, फिल्म देख लेते हैं जी, बेड में चले जाते हैं जी, वो टेम्पररी फैक्टर्स हैं. वो लॉन्ग टर्म इज नॉट गुड फॉर यू. You need your body in a different state of mind to do that, right? And one of the other big things that doesn't exist, you should regularly, and I'm saying this for myself and everyone else, you should take regular breaks. देखिए आप रेस्ट दिन में भी आपको देखना चाहिए मैं कैसे कर रहा हूँ, वीकेंड पे भी देखना चाहिए मैं कैसे कर रहा हूँ, और 3 months और 4 months के ब्रेक के बाद भी देखना चाहिए कि मैं रेस्ट कैसे कर रहा हूँ. तीनों चारों चीजें, तब आपका स्ट्रेस लेवल नीचे आएगा. डेली, वीकली और 4 months में. 4 months में फॉर एग्जांपल यू शुड डेफिनेटली गो ऑन अ ब्रेक. अपनी रूटीन से तोड़ के काम करना चाहिए आपको, एक दिन ऐड करके. अगर आप नहीं कर रहे, आपके स्ट्रेस लेवल्स नीचे नहीं जा रहे, यू विल हैव प्रॉब्लम. सो एंजाइटी बिकम्स इवन मोर प्रेवलेंट, और जब हैबिट बन जाती है इट बिकम्स इवन मोर अ प्रॉब्लम. सो इंसोम्निया इज अ वेरी बिग इशू. A lot of things play a role in it, and I am saying this again and again. Yes, benzos is, it's very commonly prescribed in Pakistan, but it's a very very big issue. Not only just Pakistan, a lot of
basically तो ये issue है ना हमारे यहाँ के, वो over the counter available है और कोई check नहीं है. ये भी तो बात है ना.
That's a big factor, and that's why there is a lot of abuse of benzos, and that's why people think it's okay to इसको दे दो लगा दो है.
अच्छा, दूसरा मेरा सवाल ये था कि कैलुला के मुतालिक आपका क्या ख्याल है? जो दोपहर के खाने के बाद जो है वो जो लोग हमारे यहाँ खासतौर पे कुछ खवातीन हैं जो लाजमी उसको एक फरीजा समझ के सर अंजाम देती हैं, तो इस कैलुले का भी इफेक्ट होता है इंसोम्निया पे?
So, okay, so let me answer this question in two parts. Number one, there were 3 studies out there, and one of them was a big study from the Mediterranean group. This was a study conducted in Greece में हुई थी study, एक study South America में हुई थी, और एक study Far East Asia में हुई थी, like in the Japan area. तीनों studies में ये शो किया गया था कि जब शॉप्स को बंद किया जाता है आधे घंटे के लिए और घंटे के लिए, और जो अवाम पूरी सोती है उस वक्त, उनके कार्डियोवैस्कुलर इवेंट्स, हार्ट अटैक्स, एंजाइटीज, एंड दे लिव्ड लॉन्गर. स्पेशली ग्रीक स्टडीज में, मेडिटेरेनियन ग्रुप में जब उन्होंने स्टडी किया, तो दे स्टडीड ओवर मिलियन पीपल, and then I remember the 800,000, 900,000 group came, and it was a very astonishing finding. Even if you look at humans in the older perspective, old way, when we go back, when the sun was right at its peak and our farmers or other people worked hard, it was absolutely very good to take a rest, and have a nap. And that nap should be about 20 minutes plus, 20 minutes to 45 minutes max. So that's been proven. It's sort of called, इसको हम कहते हैं biphasic sleep. रात को भी सोना, लेकिन एक नैप इसलिए ले रहे हैं कि हमने बॉडी को एक्सर्ट किया है और हमें एक और नैप लेना चाहिए. मैं आपकी दूसरी एग्जांपल देता हूँ. जो लड़कियां एक्सरसाइज करके आती हैं और बॉडी रिलैक्स करना चाहती हैं, वो आके आप देखेंगे कि उनका दिल कर रहा होगा कि मैं एक छोटा सा नैप ले लूं, क्योंकि बॉडी डिमांड करना शुरू कर देती है, and it becomes more rejuvenated afterwards. So nap lena and cannula, for example, I strongly believe in it. I think it's a brilliant thing. There was a reason why Prophet did it. But you have to remember, उनका जिस जगह पे वो थे, वहां पे temperature was in the 50s all the time, and it was hard. मैं उस दिन बाहर टेक्सास में थोड़ी देर के लिए रन करने गया. जब मैं वापस आया हूं, मैं सिर्फ पार्किंग लॉट में थोड़ा रन करके आया. I was drenching. वहां पे पसीनो हो गया. The point being, then your body needs it and it's fine. The question really is, आप ये रात के साथ आपको जरूर टैली करना चाहिए, और ओवर स्लीपिंग नहीं करनी चाहिए. ओवर स्लीपिंग भी बैड है, लेकिन it's much better than under sleeping. So that's the point. I think cannula is okay. You have to do it properly. Structured power naps are healthy. So I just want to answer that in that way.
एक और मेरा क्वेश्चन था, वो आपसे मैं करना चाह रहा हूँ कि जैसे कॉग्निटिव बिहेवियर थेरेपी है, उसमें जो हदीसों में कुछ आयात का जिक्र है कि अगर हम वो पढ़ें तो वो नींद जो है वो आ जाती है, क्या वो काम कर लेती हैं?
So very good question. Are there things out there that relaxes your mind? You know, it's a very good question in this way. There was a reason why Allah subhanahu wa ta'ala sent Quran in a book form. Book form, अगर आप absorb होते हैं और उसको read करते हैं ना अच्छे तरीके से, it's one of the maximum ways you can relax your mind. फिल्म देखने से नहीं, फोन देखने से नहीं, गाना सुनने, टीवी गाना सुनने, रीडिंग करते हैं ना, जब आप अपने माइंड को डाइवर्ट करते हैं, इट्स एक्चुअली अ वेरी गुड, whether you read this Bible or any holy book, it relaxes your mind a lot. देखिए मेरी बात सुने भाई, जब आप सोते हैं ना, when you go in sleep की stages है, 1 2 3 स्टेज है. 3 स्लीप में क्या होता है, आप डीप स्लीप पे जाते हैं. कई लोग उसको ये कहते हैं कि ये सिंगिंग फेज है. उसकी वेव फॉर्म्स इतनी बढ़ जाती हैं, ऐसे लगता है कि आपसे वो the girls may show you in the afternoon, इतनी बढ़ जाती हैं कि आपको ऐसे लगता है कि आपका ब्रेन आपको सॉन्ग सुना रहा है. So verses, ayah, sounds have a powerful impact. Just remember that. So is there a role? Yes. and then it matters how you're going to do that. Okay, so it's a
Thank you.
very useful tool to
Thank you
use.
very much. Thank you. अच्छा, आखिरी सवाल है मेरी तरफ से कि जो आप phases of sleep कह रहे हैं, ये सिर्फ हम हिस्ट्री लेके पता करेंगे या इसका कोई टेक्निकल कोई हमारे पास वे है, कोई मशीन है जो हम इसको फेजेस को डिस्क्राइब कर सकते हैं?
So हम तो स्लीप लैब में इलेक्ट्रोड्स लगा के मॉनिटर करते हैं रूटीन के साथ, so that is the best way. और दूसरा ये है कि जब आप इलेक्ट्रोड्स लगाते हैं ना, तो आपको ये भी पता चल जाता है, अभी जो केस प्रेजेंटेशन नेक्स्ट करने वाली है उसमें ये भी पता चल जाता है कि आपकी स्लीप कंसोलिडेटेड है, एक लाइन में है, कि आपको मिनी अराउजल्स हो रहे हैं. देखें भाई, जब भी हम लोग सोते हैं ना, अगर आपकी अराउजल्स बहुत ज्यादा हो रही है, उनको कहते हैं मिनी अराउजल. आपको सबकॉन्शियसली पता नहीं चलता कि मैं जाग रहा हूं, लेकिन आपकी उसको कहते हैं यार मेरी स्लीप बड़ी लाइट थी, स्लीप लाइट बड़ी थी. लाइट इसलिए थी भाईजान कि आप एक्चुअली अपनी स्लीप में जाग रहे थे. आप मिनी फुल अराउजल नहीं हुआ था, बट ऑलमोस्ट फुल हो रहा था. सो दैट स्लीप इज नॉट गुड. इसका मतलब है आप डीप स्लीप में नहीं जा रहे. सो उसको कई वॉचेस हैं जो आपकी हार्ट रेट के साथ टैली करते हैं और आपको दे कैन गिव यू एन आइडिया, बट देयर इज नॉट अ लॉट ऑफ दैट स्टफ देयर. You have to get a proper sleep study done to get that measurement. So that's part of the answer.
Thank you very much. So
okay,
nice.
Absolutely. Thank you for your questions. Good. So there is a few other questions I want to quickly answer with this. The most effective treatment option for insomnia. We're going to discuss that in a little bit else. I'll probably we'll give you some tips about that. किसी ने पूछा how to stay stress free in life, and then I think the part of the question we answered is the same bit that we just discussed. Stress free रहना is impossible. Actually आप इस तरह से सोचें, थोड़ा स्ट्रेस होना is essential. ये लाजमी है स्ट्रेस होना. ये फाइट और फ्लाइट मैकेनिज्म को एक्टिवेट करता है. इसको कहते हैं सिंपैथेटिक सिस्टम, और वो एसेंशियल है हमारी सर्वाइवल के लिए. सो आई वुड आंसर द क्वेश्चन इन दिस वे. स्ट्रेस फ्री नहीं आप हो सकते, दैट्स नॉट डूएबल. बट स्ट्रेस को लेके जब आप बेड पे जाते हैं ना, दैट्स व्हेन इट स्टार्ट्स बिकमिंग प्रॉब्लम. ओके, सो दैट्स अ बिग साइन. The other question was कि sleep deprivation का क्या मुझे warning sign है. देखें, अभी बात सुने. Rule of thumb ये है, मुझे काफी पूछ रहे थे rule of thumb. अगर आप सुबह उठ रहे हैं और अगर आप, I tell the girls, अगर आप ऐसे वो फिल्मों वाला नहीं ना करती, वो जो लड़की ऐसे करती है ना, ऐसे करके ऐसे करके वो आर्म स्ट्रेच करके आई एम रेडी टू गो, अगर आप वो नहीं ना कर रही और फील नहीं कर रहे कि मैं फ्रेश हूं, oh my god I feel so good, then your sleep is an issue. या आप 2 घंटे के लिए फ्रेश फील करते हैं and then just in your 4th hour in the day you feel tired again, then you know you haven't had enough sleep or your body is not ready. So that would be a crude test. Or just generally, you should be able to concentrate. You should be able to memorize stuff. You should be able to also look into solving issues and do critical thinking. So that's all of these things are sort of like relevant. Okay. So let me go and start the next thing. इस session में अगर किसी को कोई question है, please just raise your hand. Or what we will do is answer your questions as we go along. So let me pass it on to Dr. Vijaya, Fatma, Brenda, and all the team. Sophia is going to start off a case presentation. So case presentation इसलिए कर रहे हैं कि ताकि आप you'll get an idea कि कैसे हम एक केस को कैसे हम स्टडी करते हैं.
Hello once again, everyone. So as we have discussed what is sleep apnea and how we can treat it, now we would like to present a case study on how PAP titration can be used and how obstructive sleep apnea can be diagnosed and PAP titration can be used to treat it. And for that, I will be needing the help of my whole team, including Dr. Vijaya, Dr. Fatma, Dr. Jana. So the patient that we have selected today is a 68-year-old male with BMI of 30.3, presented with main complaints of snoring, choking, gasping in sleep, daytime fatigue, and witness apneas. And the apneas and the fatigue was noticed by the patient's partner. And he showed an Epworth score of 23. So I'm just going to touch a little bit based on what Epworth score is. So Epworth score is actually an assessment of the daytime somnolence of the patient. It actually comprises of 8 questions, and we have a score from 0 to 3, ranging from never dozing or slight chance of dozing to high chance of dozing. It gives us an idea about how severity of the sleepiness that the patient might be experiencing. And the patient that we have today has an Epworth score of 23. So he had a very severe daytime somnolence going on. With this, the patient had medical history of COPD, diabetes mellitus, benign postherpetic hyperplasia, dyslipidemia, pulmonary embolism, and hypertension. So he had a lot of comorbidities going on with him as well. The medications include Trelegy, Ellipta, ipratropium albuterol. These are the bronchodilators. Cyclobenzaprine, this is a muscle relaxant. Valium, that is an anxiolytic. With this, he's taking medication for his diabetes, for his BPH, and he's also taking medication for the GERD. Now, in front of you, this is an epoch of 30-second interval, and I would like to walk you guys through the diagnostic polysomnography, which is done in order to check and analyze the patient's sleep and the sleep patterns and identify any abnormalities. So this is a 30-second interval, which is known as an epoch. And the whole of the study that is done, that is in clinic sleep studies that is done, it comprises of around 700 to 800 pages of similar epochs. And we go through this every day. And having this raw data, we compile it, and then we formulate a report that I will be showing in some time as well. On your left-hand side, you can see that there are a few leads. I'm just going to go over briefly to give an overview, because we have to check each and everything of the patient while the patient is sleeping. So on the top, you can see that there are 2 central leads, 2 occipital leads. In some cases, we do have a frontal leads as well. So these are the brain leads. They actually help us measure the brainwave activity during the sleep. Below them, we have left eye and right eye leads. They actually help us identify and distinguish the REM sleep from the non-REM sleep to record the eye movement. After that, we have the chin leads that help us identify bruxism, or when there's teeth grinding, and when the patient has gone to sleep and when he's awake as well. With this, in some cases, we do have the leg leads, as it was shown by Dr. Jannat in her presentation, that help us identify the PLMs and score them, the periodic limb movements. The ECG lead help us to calculate the heart rate and track the rhythm of the patient. And then we have the few airflow sensors. In some cases, there is a pressure flow. In some cases, we have both thermistor flow and the pressure flow as well. They help us in measuring breathing patterns, detect apneas and hypopneas. And with these, we have the thoracic and abdominal lead that help us marking the respiratory events, whether it is an obstructive event or there is a loss of drive from the CNS. Abdominal lead measure the movement of diaphragm, and thoracic lead, it measure the movement of the thoracic cavity. In the end, we have the saturation lead and the heart rate lead to measure the oxygen desaturations and the heart rate fluctuation, including bradycardia and tachycardia. That is how we normally set up our patient. The central leads are put on the scalp electrodes to measure the brain activity, the airflow sensors like the T-flow and P-flow. Then we have electrodes on chest to measure.
So I'm going to interrupt. So just for everyone, सबके लिए patient, God, ऐसे जब देखो तो ऐसे लगता है ये कोई एलियन आ गया है फ्रॉम किसी और प्लैनेट से. और जस्ट टू से, अगर हमने प्रॉपर उनकी ब्रेन की एक्टिविटी, हार्ट की एक्टिविटी, उनके लंग्स की एक्टिविटी और उनकी ब्रीदिंग पैटर्न्स मॉनिटर करना है तो उनको कनेक्ट करना पड़ता है. और ऑन एवरेज एक स्लीप टेक को अप्रोक्सीमेटली आधा घंटा 20 to 30 मिनट्स लगते हैं एक पेशेंट को सेटअप करने के लिए. पर इससे फायदा ये है कि यू कैन मॉनिटर एवरीथिंग. वी मॉनिटर उनकी आईज मूवमेंट कैसे चलती है, उनका ब्रेन कैसे चल रहा है, वो सांस कैसे ले रहे हैं, हार्ट उनका। इसके बगैर आप डायग्नोज नहीं कर सकते और रूल आउट नहीं कर सकते। और डॉक्टर सोफिया बताएंगी एक दो एग्जांपल के साथ। सो ये इसलिए ये ड्रोनी पिक्चर लगाई गई है कि आपको थोड़ी सी दिखाने के लिए कि ये असेंशियल है। बट मैं आपको ये कह सकता हूँ, आप जब सुबह जाएंगे वापस, आप सोते भी बड़ी आराम से हैं, क्योंकि ये सेंसर्स जो है ना बहुत लाइट है, सारे सेंसर्स बहुत आराम से उतर जाते हैं बॉडी से। और दूसरा ये है कि जब आप सुबह जाएंगे तो आप पे निशान भी कोई नहीं होगा और उसका कोई साइड इफेक्ट नहीं है। दैट्स द अदर लिटिल प्रॉब्लम। पर लाइक आई सेड, आप ऐसे इनिशियली जब आएंगे तो ऐसे लगता है कि यार ये मुझे क्या लगा दिया है इतना कुछ, लेकिन इसका फायदा बहुत ज्यादा है। Alright, so this picture, that's why it's very important कि आपको familiarity हो। क्या क्वेश्चन आता है कि क्या बच्चों को भी ऐसे किया जाता है? जी, बच्चों को भी ऐसे किया जाता है। क्या बच्चे प्रॉब्लम करते हैं? नहीं, बच्चे प्रॉब्लम नहीं करते। एक्चुअली बच्चों को लगाना ज्यादा इजी है। एक दफा वीडियो गेम लगा दो, वो आराम से, उनको जो मर्जी लगा दो, उनको पता नहीं चलेगा। तो लैब्स पे वीडियो गेम्स वगैरह रखी होती हैं जो उनको डिस्ट्रैक्ट किया जाता है। और ऑन एवरेज कोई भी रात को उठ के ये नहीं करता ये कि मुझे क्या लगा दिया है। सो इट्स वेरी वेरी पेनलेस, कोई पेन नहीं होती। ओके सोफिया, गो ऑन टू नेक्स्ट।
So now that Dr. Khan and I have discussed how the electrodes are put up and how a PSG raw data looks like, so we're just going to dive into the real PSG data for the patient that we have selected for our case study. So
तो
this
अभी
is
जो नेक्स्ट जो
on the
स्लाइड दिखा रही है वो उसमें आपको स्लीप स्टडी दिखा रही है। हम हर 30 सेकंड मॉनिटर करते हैं। आपके सामने ये 30 सेकंड का एक पेज है और इस पेज से हम क्या इंफॉर्मेशन ले रहे हैं? उनकी ब्रेन की एक्टिविटी, हार्ट की, ऑक्सीजन की, और वो सांस कैसे ले रही हैं। दैट्स वेरी इंपॉर्टेंट। जो देखे ना भाई, कोई भी है, आप जब रात को सोते हैं ना, ये एसेंशियल है कि आपका ब्रीदिंग जो है ना वो स्मूथ हो। वो गराड़े लेना हाली इशू नहीं है। इशू तब होता है जब आपकी चेस्ट सही तरह से मूव नहीं कर रही होती। सो दिस इज वेरी इंपॉर्टेंट जस्ट टू टेल यू ऑल कि आपका एम ये है, हमारा एम ये है कि जब आप सोएं तो एक स्लीप फेज से दूसरे और तीसरे फेज में जाएं और ये ट्रांजिशन स्मूथ होनी चाहिए। और जैसे हमने कहा कि नॉन रेम स्लीप में और रेम स्लीप में आप रात को जरूर सोएं। ड्रीम करना इज वेरी इंपॉर्टेंट सबके लिए। ड्रीमिंग इज वेरी इंपॉर्टेंट, like we just discussed, and I don't know if you guys heard the first presentation, but that's what सोना और ड्रीम करना is normal. Okay, so let's go next, Sophia.
So at the top of the PSG epoch, we can see that we have a lot of fluctuations that we can see, as Dr. Khan was saying, that you have to go to REM sleep in which you are dreaming. You have to go to N3, that is the deeper part of sleep. But in this patient, you can see that patient is waking up again and again. And the only two phases that the patient is going is N1 and N2. And now I'll just try to explain the changes that you can see that one of our audience was asking, that how can we decide whether the patient is sleeping? How can we decide whether he's going to N1, N2, N3, N4, and REM sleep? So here, when the patient is awake, you can see that the frequency of the waves that the brain is collecting, it's very high. There is high amplitude, high frequency waves. The eyes are moving. This is like a blinking movement of the eyes. With this, the chin is also, it's tensed a little bit. So the patient is awake at this time. But then when the patient goes to sleep, you can see that now the waveform, the frequency has reduced markedly. And here we can see that there is alpha waves, which are slower waves as compared to beta waves that is seen when the patient is awake. And in alpha waves, we are also seeing SEM movements, that is slow eye movements.
Yeah,
that is
I
mostly
think
like
we
the reading
leave
movements.
पता है क्या है, इनको आम जुबान में सिर्फ ये दिमाग slow होना is a sign of sleep. That's what Sophia is trying to say. The other things we don't want to go into too much detail with that. ये पीछे बैकग्राउंड में आप वेक नजर आ रही है, फ्रीक्वेंसी हाई है, लेकिन जो ही आपका ब्रेन रिलैक्स होता है वेव फॉर्म स्लो होना शुरू हो जाती है। और ये रिलैक्सेशन बहुत इंपॉर्टेंट है, ये आपको किसी भी दुनिया में जगह से नहीं मिलेगी। आप या ड्रग्स देंगे पेशेंट को तब आएगी, या आप नेचुरल इंड्यूस करेंगे, आपके पास चॉइस है कि आपने कैसे करना है। Okay, so let's move on to the next bit. Just overview it. We don't want to go too much into it. Just essence ये है कि ये phases में आपने देखना है, जहाँ पे सोफिया ऊपर बता रही है, एक नजर ऊपर बस नजर रखें कि कितनी टूटी हुई स्लीप है। डीप स्लीप में N1, N2, N3, ये बाद में फातिमा आपको दिखाएगी कि ये कैसे नजर आ रहा है। Let's see if Arshia has a question. Arshia, you can come in and ask the question if you want to. You can interrupt us. कोई भी आके interrupt कर सकता है। Arshia, I think she had her hand up. If you have a question, you can ask and unmute yourself. So, Hamza bhai, if anyone wants to ask a question, just have them, Arshia come on and she can ask. Okay, go on. And meanwhile, just keep going. You can interrupt us.
So
Amber
in this,
as well and
yes.
Arshia as well.
So in this,
Go on, Amber, you have a question.
so in this diagnostic study, the
Yes, I
overall
wanted
thing
to
that
ask, excuse me. Yeah, I wanted to ask, what is the solution for sleep tremor or sleep paralysis?
Okay. So I got your question. I'm going to answer that question. Give us a few minutes and I'm going to ask sleep tremors and sleep paralysis. Actually, you may have been away. We answered that question, but I'll answer it again. Okay. Dekhe, sleep paralysis. Let me just tell you one point. Paralysis का मतलब है जब आपकी बॉडी मूव नहीं करती, आपकी बॉडी मूव नहीं करती रात को। एवरी पर्सन, इफ यू स्लीप प्रॉपरली, आप स्लीप पैरालिसिस में जाते हैं, बिल्कुल उसी तरह से जैसे आपको एनेस्थीसिया दिया जाता है और आपकी बॉडी मूव नहीं कर सकती। दैट इज कॉल्ड स्लीप पैरालिसिस। और वो कब जाते हैं, किस फेज में जाते हैं? स्लीप की, व्हेन यू हैव रेम स्लीप। सो आपको अभी दिखाएगी सोफिया फॉरवर्ड करके, सोफिया जस्ट फॉरवर्ड है, जस्ट लो अस नॉन रेम स्लीप। नॉन रेम में हमें पता चल जाता है कि आप रात को ड्रीमिंग कर रही हैं, और उस वक्त हम आपकी ऑक्सीजन और हार्ट रेट कैलकुलेट करते हैं। सो ये इस पेशेंट में, पेशेंट रेम स्लीप में गया ही नहीं है, इसलिए नहीं गया कि उसको ऑब्स्ट्रक्टिव इवेंट्स हो रहे थे। सोफिया बताती है, जस्ट शो अस एन ओवरव्यू ऑफ द, सोफिया जस्ट एन ऑब्स्ट्रक्शन कैसे हो रही है, कि ऑक्सीजन कैसे ड्रॉप कर रहा है। और ऑक्सीजन ड्रॉप करना इज अ साइन ऑफ स्ट्रेस इन द बॉडी। ऑक्सीजन आपको, यू ऑलवेज नीड इट नियर 98-100%। सो नंबर वन, स्लीप पैरालिसिस इसलिए होता है, ये नॉर्मल फिनोमेना है, लेकिन आप स्लीप पैरालिसिस के वक्त उठना नहीं चाहिए आपको। अगर आप उठ जाएंगे, कभी कभी ऐसे भी होता है नॉर्मली कि आप उठे हैं और आप कहते हैं ओह माय गॉड, मैं बॉडी नहीं मूव कर सकती या कर सकता, इसलिए कि आपको अगर कोई नॉन रेम स्लीप में जगा देना, आपकी ड्रीम स्लीप में, तो तब आपको स्लीप पैरालिसिस होता है। सो दैट्स नंबर वन। ओके, sleep tremors की definition is a little bit different. Sleep tremors भी a lot of time parasomniac effect की वजह से आता है। और उसमें क्या होता है कि आप जब स्टडी करते हैं पेशेंट को, वो अमूमन नॉन रेम स्लीप में आती हैं। स्लीप ट्रेमर्स और स्लीप टेरर्स, किड्स में टेरर्स होते हैं क्योंकि वो डर जाते हैं स्लीप से, वो उठते हैं और उनको ड्रीम याद होता है, बिल्कुल उसी तरह, और वो ड्रीम हमेशा बैड होता है, इसलिए उनको पता चल जाता है। सो the answer to your question would be, आपकी थोड़ी हिस्ट्री देखनी पड़ेगी, मेडिकेशंस देखना पड़ेंगे, आपका स्लीप पैटर्न देखना पड़ेगा, और ये देखना पड़ेगा कि आप लेटर हाफ ऑफ स्लीप में क्यों उठ रही हैं। So we'll discuss that in the next, sort of like in coming session. All right? जी मिर्जा भाई, आपका क्वेश्चन है कोई? Okay, go on, Sophia. Just give us a quick overview, then so we can, on the, while Mirza Bhai comes back on, If he doesn't, then we'll go on to have just finish your bit here.
So,
जी खान भाई मैं ये पूछ रहा था
yes.
कि जितने
So
इलेक्ट्रोड्स
now,
लगे हुए हैं, एक्सक्यूज मी प्लीज, जितने इलेक्ट्रोड्स लगे हुए हैं इसमें जो अडल्ट है उसको नींद आ जाती है?
वेरी इजी, मैं इसी आपके लिए कह रहा था, हर पेशेंट सोता है। असल में देखने में बुरा लगता है, लेकिन जब आप लगा देते हैं ये फील भी नहीं होता कि लगे होते हैं। वेरी फाइन थिंग्स, सो वी डोंट हैव एनी प्रॉब्लम्स विद दैट।
राइट, थैंक यू।
Go on, Sophia, just last 1 minute.
So for the marking of the respiratory events, we actually go to 4 minutes, and we can see that there is straight line, and that actually tells us that the patient has stopped breathing. And now I would like to ask Dr. Fatma if she can explain the results, and then we can go on with this case study.
So just so it's an oxygen saturation, where does it go low? ताकि audience को देखे कि आपकी breathing. Just show us where the oxygen
went down. So it went down to like 75, 73, and even in the 60s as well.
Okay.
And his minimum saturation was in 50s.
Saturation का नाम है जब आपका ऑक्सीजन बॉडी को क्या मिल रही है, और इस केस में एवरी टाइम पेशेंट जब सांस रोकता है, लाइन फ्लैट होती है, ऑक्सीजन लेवल ड्रॉप कर जाता है. ओके, इज दैट राइट?
Yes, sir.
Okay.
And after calculating the raw data, we actually formulate this final report. And Dr. Fatma?
Yeah, thank you, Dr. Sophia, for handing it over to me. So I will be walking you through a diagnostic for insomnia. Can you hear me?
हाँ, keep going. So
Okay.
आप बता रही थी कि टेबल में डाटा कंप्यूट होगा. Okay.
Yes, sir.
So this
sir,
is the...
Okay.
Keep going, Fatma. Let's finish yours. Good.
Okay, so as you are all aware that patient demographics are the vital section of the report, which Dr. Sophia has already discussed. So moving forward, the next part of the report covers a brief clinical history. And in this particular case, patient presented in sleep lab with complaints of snoring, choking, gasping, daytime fatigue, insomnia, and sleep talking. And in the next part, we review the clinical medication history as previously discussed by Dr. Sophia. And in the impression section, we will find all the findings that occurred during the sleep study. Sophia, can you please move it to the impression section? Yes. So in this case, patient demonstrated severe obstructive sleep apnea as the patient had an overall AHI, which is the apnea-hypopnea index of 96 events per hour of sleep. That means patient stopped breathing 96 times in 1 hour. That's a lot, and it should be less than 5. And the next thing will be the patient's oxygen saturation, which is very low. That is 59%, and it should be like more than 97%. Then there will be no leg movements as noted, so the patient did not have any PLMS disorder, and Jannat has already explained very well about the PLMS disorder. The sleep architecture was notably disrupted. The patient's sleep efficiency was only 55.8%, and he experienced 138 arousals with an index of 45.5 per hour, which
138 arousals.
138
was
arousals.
45 arousal per minute per hour.
Yes.
यानी हर घंटे में 45 दफा पेशेंट उठ रहा था और उसको पता नहीं था, और उसकी ब्रीदिंग स्लीप एपनिया, एपनिया का मतलब ब्रीदिंग स्टॉप कितनी दफा हो रही थी? 90 टाइम्स पर आवर, यानी कि 90 दफा उसकी ब्रीदिंग रुक रही थी और 45 दफा पर आवर वो पेशेंट उठ रहा था, और उसके ऑक्सीजन जो है वो 59 तक ड्रॉप हो गए हैं, जो कि नॉर्मल लेवल इज 100. आप भाई कोई भी है ना 5 से 1 2 3 दफा रुक सकते हैं ब्रीदिंग पर आवर, लेकिन जब ये लेवल सिम्टम्स के साथ आना शुरू हो जाता है ना, स्नोरिंग के साथ, टायर्डनेस के साथ, हेडेक्स के साथ, फटीग के साथ, सो दिस इज वेरी अलार्मिंग. फिर बहुत ज्यादा अलार्मिंग हो जाता है. ये पेशेंट इंसोम्निया भी कह रहा था मुझे है, स्नोरिंग भी कर रहा था, फटीग भी था, और स्लीप में टॉक कर रहा था। आप स्लीप में जब आपकी नींद इतनी स्ट्रेस हुई होती है तो आपको स्लीप पैरालिसिस, स्लीप ट्रेमर्स, स्लीप टॉकिंग, और लोग स्लीप वॉकिंग करते हैं पैरासोम्निया में। ऑफ कोर्स हम जब ये स्टडी करते हैं तो हम सीजर्स रूल आउट करते हैं, हम मेक श्योर करते हैं कि ब्रेन में सीजर्स तो नहीं हो रहे, कोई ट्यूमर तो नहीं है, कोई और पैथोलॉजी तो नहीं है। सो ये रिपोर्ट इसको एक्सट्रैपोलेट करती है। ये है फातिमा का। फातिमा, गो ऑन, फिनिश। इज देयर एनीथिंग एल्स?
Yes, sir. So next I will be explaining about the hypnogram. So the hypnogram is a graphical representation of sleep stages like stage of wakefulness, rapid eye movement, commonly known as REM, and non-REM sleep stages that are N1, N2, N3 with heart rate, oxygen saturations, and respiratory events. So here on the top, you all can see the sleep stages are represented in different colors and lines, showing the sleep stages of sleep. However, in this case, patient goes to only N1 sleep stage and N2 sleep stage as patient was having a lot of arousal and wakefulness due to respiratory events.
So आपको सही अंदाजा होगा जब हम इसको ट्रीट करेंगे ना, अभी आपको नेक्स्ट दिखाते हैं, तो तब आपको पता चलेगा कि ट्रीटमेंट के बाद कितना बेहतर हुआ है. So let's go on to next. Let's see, Fatima, let's move on to the treatment part.
Okay, sir. Now I will hand over it to Dr. Wajiha, so she will go over the treatment part.
Thank you, Dr. Fatima, to handing over to me. So, as you guys know that we have just discussed the diagnostic study, that we develop a diagnosis that a patient has been suffering from OSA. Okay. Then after that, to treat that, we have an idea from Dr. Fatima's presentation that यहाँ पे devices use only for the treatment. But हम वहाँ तक जाएंगे कैसे? Like we need some test to get an idea कि कौन सा mask कौन सा device use होगी. So here in this study, we actually give the patient different pressures and then the mask according to the patient's need. And there are two types of pressures, that is CPAP and BiPAP. In CPAP, we give one type of the pressure, and if the respiratory events like the obstructive apneas आ रहे थे, अगर वो treat नहीं होते, then we will move to the bi-level, यानी हम दो pressures दें, ठीक है, ताकि patient की जो condition है, it should be cured. After that, for example, in this patient, let's start with this patient. We started giving the pressure of CPAP 6. Then gradually we increased the pressure to 12 CWP. But what happens that respiratory events were not eliminated in this patient. So we shifted the patient to BiPAP. Like हमने उनको दो pressures दी. दो pressures देंगे. After that, कुछ जो है वो events खत्म होना start हो गए. ठीक है. By 19 by 15 we started giving the pressure. But what happens that it was not eliminated completely. So we increase the pressure and then we get the final pressure that was 22 by 18. So in this pressure, this was the optimum pressure जहाँ पर patient easily सो रहा था. And as you can see in the polysom in G3, Sophia, can you, yes, REM. As we have discussed that the patient deep sleep में जाएगा, then we have the REM and the N3 sleep. इस patient में after titration and after giving pressures, we achieve the N3 and REM. So which means that we have achieved our goal. हमारा ये goal था कि patient peacefully सो.
And और सबके लिए एक point के ऊपर red line जो नजर आ रही है ना, ये bad line नहीं है, ये actually good line है.
Yes.
और इसका मतलब ये है कि patient consolidated sleep, persistent sleep, गहरी sleep में सोया हुआ है. और क्या कर रहा है इस केस में? ड्रीमिंग कर रहा है. REM sleep इसको कहते हैं, REM sleep. In fact, जब हमने इसको प्रेशर दिया तो उसको साथ ही ख्वाब आना शुरू हो गए. एंड दैट इज वेरी वेरी, आप ये लाजमी नहीं है कि आपको उठे तो सारे ख्वाब याद हो. ख्वाब की मैकेनिज्म इज वेरी डिफरेंट. रेम स्लीप में आपके जो टाइम है ना वो स्लो हो जाता है, और उसका मेन मकसद ये होता है कि आपके हिप्पोकैम्पल में वो सिनेप्सिस, वो न्यूरॉन्स बनना शुरू हो जाए. सो रेम स्लीप इज वेरी एसेंशियल. अगर आपको गुड ख्वाब नहीं ना आ रहे ख्वाब रात को, गुड हार्ब, स्ट्रेस हार्ब नहीं, गुड हार्ब्स, तो आप ये एक साइन है कि आपकी स्लीप ठीक नहीं है. सो अच्छे सुहाने ख्वाब आना इज एक्चुअली अ साइन, हेल्दी साइन कि आपकी स्लीप इज इन गुड फेज. अगर आपको ऑक्सीजन गिर रहा है तो आपको ख्वाब वाब नहीं आने लगे, रात को जिन नहीं आएंगे खाने के लिए, कुछ वो भूत वगैरह वो आएंगे डराने के लिए, या आप किसी कब वो कहते हैं ना कुएं में गिर रही होंगी, चीख रही होंगी, कोई पीछे पड़ा होगा आपके, स्केरी हाब्स आएंगे. तो अच्छे हाब्स आना और हेल्दी हाब्स आना इज एक्चुअली साइन कि आपकी स्लीप जो है ना इज पीसफुल. So that's one of the litmus things. So let's move on to next so we can see if there's any other things with that.
Yes, sir. I would like to ask Dr. Jannat to go over the report and the final results of the titration. Thank you.
Okay, so let's move on to the report direct. Okay, so this is the CPAP and BiPAP titration report of the patient. So as Dr. Vajiha has discussed that at first we gave the patient CPAP, but we were not able to eliminate all the respiratory events. Then we gave the patient BiPAP, which are basically two pressures. One is the inspiratory pressure and one is the expiratory pressure. So at a BiPAP of 22/18, the AHI was 1.7 and the respiratory events were abolished. And we can see that as compared to the overnight diagnostic study, the patient had very few arousals, which means that the patient achieved good sleep and the sleep architecture was very consolidated. And we can also see that there is clearly a difference in the sleep efficiency. So in the PSG, the sleep efficiency was 55%, and we can clearly see that patients slept well with a sleep efficiency of 95.9%. And very important thing that Dr. Khan has mentioned that the patient was able to achieve REM. So this is the hypnogram, and let's look at it. So at the top line, we can see that the patient was able to initiate sleep early, and then the patient went directly into the deepest stage of sleep, which is the N3 sleep. And this was not achieved on the overnight diagnostic study. And then the patient had 3 to 4 cycles of REM sleep. And we can see that at the CPAP pressures, he was not able to sleep well, and we were not able to eliminate all the events. But at BiPAP, the patient was sleeping very well. There are just a few respiratory events that we can see. So next thing, let's look at the heart rate. So we can see that there are quite lesser fluctuations in the heart rate, which is good. And then we can see the saturation. So in the overnight diagnostic, the saturation was 59%. That was the lowest. But in this BiPAP study, when the patient was given BiPAP pressures, the saturations drastically improved. And the patient's baseline saturations were in the 90s. And then we can see that there are clearly less arousals. We can see that at the CPAP pressures, patient is having a lot of arousals, and then towards the end of the study, towards the second half of the study, clearly there are lesser arousals and the sleep architecture looks more consolidated. So I think this hypnogram shows a dramatic effect of CPAP and BiPAP titration that the patients have who are suffering from sleep apnea.
Yeah.
So after we set up the patient and we did some follow-ups and guided the patient of how PAP therapy can help the patient, this is the compliance report of the patient. And it shows that how the AHI has drastically decreased from 96 per hour to 0.3 per hour. And when we guided the patient properly, patient was able to use the BiPAP therapy for at least 7 hours per night. That made his compliance very well. So following the PAP titration, the patient experienced substantial clinical improvements, and there were clear reduction in the apneas and the hypopneas that ultimately led to enhanced sleep quality, resulting in better daytime alertness, and overall quality of the life of the patient was increased as stated by the patient himself. With this, the patient oxygen saturation levels were much more maintained within the normal ranges during the sleep. And the patient has come for follow-ups with us and has stated that how his life has dramatically been well after the PAP therapy.
I think that was very good.
So,
हमें एक रिजल्ट ये भी पता चलता है, पैप जब लगाते हैं ना तो बहुत ज्यादा लोग पैप लगाने से पहले लोग बहुत डरते हैं, फोबिया होता है, डरते हैं, कहते हैं कि यार ये मुझे क्या मशीन लड़ गई है, सारी जिंदगी ये क्या मुझे साथ कहाँ पे लेके। लेकिन मैं आपको एक बात बता सकता हूँ फ्रॉम सीइंग थाउजेंड्स ऑफ पेशेंट्स, कि वो अपनी बीवी को छोड़ने के लिए तैयार होते हैं लेकिन पैप मशीन को नहीं छोड़ते एक दफा जब लग जाती है, क्योंकि उनको इतनी जबरदस्त नींद आती है उसके साथ, और वो इतने आदी हो जाते हैं उसके कि एक दिन भी नहीं सो सकते उसके बगैर, और उनको कंपैरिजन मिलता है कि यार बुरी स्लीप कैसी है और गुड स्लीप कैसी है। सो इट्स अ ह्यूज ह्यूज डिफरेंस बिटवीन द टू, कि दोनों ट्रीटमेंट्स में फर्क कैसे पड़ता है। सो दैट्स अ लिटिल पॉइंट आई वांट टू गिव। वहां पे अभी तक मुझे नहीं पता कि कोई कितनी ट्रीटमेंट्स हो रही है पाकिस्तान में। देयर इज ऑब्वियसली वहां पे बहुत ज्यादा लैक है, ये एज अ स्पेशलिटी एग्जिस्ट नहीं कर रही। सो हम कोशिश करेंगे, दुआ करेंगे कि और ज़्यादा अवेयरनेस लाएं। और टेक होम मैसेज ये है कि ऑब्वियसली ग्रुप ने बहुत ज़बरदस्त प्रेजेंटेशन की है, और एक दो और प्रेजेंटेशन ज़रूर करेंगे किसी और जगह पे जहाँ पे ज़्यादा ग्रुप आके ये सुन सके कि इसके फ़ायदे क्या हैं और स्लीप के नुकसान कैसे ना करने से क्या नुकसान है। सो लेट मी टेक वन क्वेश्चन, और फिर हम लास्ट मैं एक दो टिप्स देना चाहता हूँ स्लीप के बारे में। एक दो स्लाइड्स हैं, आप आई गिव यू अ फ्यू टिप्स, और फिर हम उसके बाद विल जस्ट कंक्लूड इट इफ देयर इज नो क्वेश्चंस। विल जस्ट टेक वन क्वेश्चन। आई थिंक मिर्जा साहब हैज अ क्वेश्चन, विल जस्ट ट्राई टू आंसर हिज क्वेश्चन।
हाँ जनाब, बहुत ज़बरदस्त सर प्रेजेंटेशन भी, और जो भी आपकी टीम ने बहुत काम किया। लेकिन मैं ये पूछ रहा हूँ, लाहौर में अवेलेबल है ये इन्वेस्टिगेशन और ये ट्रीटमेंट, कोई सेंटर है अवेलेबल?
ये मुझे
Sir,
पता है कि हाँ, go on. Just someone
Sir,
want to
I
answer.
would like to tell you that yes, in Jinnah Hospital, Lahore, we have this opportunity present. So yes, people can get their sleep studies done from there.
Thank you very much.
Okay, thank you.
Okay, let's just go over a few tips and interrupt me. किसी भी कोई किसी ने कोई interruption करनी हो, so you can by all means do interrupt. Okay, so what is the important things that I want you guys to remember in this? Number one, अगर इस टॉक के बाद एक मैसेज आपको घर लेके जाएंगे ना, वन मैसेज दैट आई वांट यू टू टेक होम इज दैट स्लीप की रूटीन को ना तोड़ें, वीकडेज हो या वीकेंड्स हो, ट्रिप पे जा रहे हो या ना जा रहे हो, कोई इमरजेंसी आ गई है, कोई एग्जाम आ गया, अपनी स्लीप का रूटीन मेंटेन करना बहुत इंपॉर्टेंट है। आप ऐसे समझ लें कि जब आप स्लीप को डिसरप्ट करते हैं ना, तो अंदर आपके हार्मोन्स का एक तूफान होता है, आप वो सब डिस्टॉर्ट कर देते हैं। ये भूल जाए कि मेलाटोनिन क्या होता है, एडेनोसिन क्या होता है, ग्रोथ हार्मोन क्या होता है, कोर्टिसोल क्या होता है। आप स्लीप को जब डिस्टरप्ट करते हैं ना, तो आप अपने अंदर लाइक आई सेड खलमली वो खलमली खुलमली क्या मचा देते हैं, बस वो मचा देते हैं कुछ ना कुछ केओस। ऑलराइट, आपने वो कर दिया, और आपका ये और हमारा और आपका ये टास्क है कि वो खुलमली ना मचाई जाए, वो गड़बड़ ना की जाए। ओके, और उसका एक ही तरीका है कि आप स्लीप को जैसे चल रहा है वैसे चलने दें। और ये याद रखें, बाय द वे, मैंने जैसे आपको बताया स्लीप रूटीन में सिर्फ ह्यूमंस ही वो स्पीशी है जो इसको डिसरप्ट करता है, बाकी कोई लिविंग बीइंग ऑन प्लैनेट अर्थ अपनी स्लीप की रूटीन को डिसरप्ट नहीं करते, सिर्फ ह्यूमंस करते हैं। इवन कोई बंदर हो जाए, लायन हो जाए, जिराफ हो जाए, शेर हो जाए, कोई भी अपनी रूटीन को, सो वेक अप टाइम, स्लीप टाइम, उसको रेगुलेट रखें। ओके, सो दैट्स माय फर्स्ट टेक होम मैसेज। और जैसे हम ये बात कर रहे थे, आप दूसरा मैसेज क्या है, आपने अपने रिलैक्सेशन टेक्निक ढूंढने हैं। ये इंपॉर्टेंट है, और वो बेड पे लेके जाने हैं। और जो चीजें स्ट्रेस कराती हैं उनको बाहर रख दें, बाबा उनको ना लेके जाएं बेड पे। सो सेकंड थिंग ये है कि आप जो है अपने साथ एक बुक ले जाएं, दैट्स गुड। आप अपने साथ कहते हैं कि जी मैं जाने में स्लीप का टाइम, स्लीप का अलार्म जरूर लगाएं, जागने के लिए नहीं, सोने के लिए। सोने से अपने टाइम से अलर्ट 15 मिनट या 2 घंटे पहले एक अलार्म लगाएं कि ओहो, अपने आप को याद करवाएं स्लीप माइंड में कि मैंने सोने जाना है। ये इंपॉर्टेंट है। ये ना भी जाए कोई बात नहीं, लेकिन अलार्म जरूर लगाएं। अपने ब्रेन को इंट्यूशन दें कि यार, एक होता है पोक करना, पोक करते हैं ना मीम के साथ, पोक फेल भी हो जाए आपको याद रहती है, यार इसने मुझे छेड़ा था। अपने आप को जरूर छेड़ना है। बदला बाद में लेना है, बदला ये नहीं याद के बदला लेना है या नहीं लेना, लेकिन ये याद होता है कि यार इसने मुझसे पंगा किया था। आपने स्लीप का पंगा करना है लाजमी। और बेटर है कि 2 घंटे पहले या 15 मिनट पहले अपने आप को रिमाइंड जरूर कराएं। उसके बाद आप पे ये होना चाहिए, हो यार ये मेरे स्लीप का टाइम था, मेरे स्लीप, ये भी गुड आदत है। ये भी गुड आदत है अपने आप को याद कराना। आपका ब्रेन के जो हार्मोन्स है ना वो खराब नहीं होते, वो उनको पता है कि यार ओहो ये आज कर रही है इसलिए हो रहा है, लेकिन मैं फिर उसी टाइम पे आऊंगी। लेकिन जब आप भूल जाते हैं ना, टाइम नहीं रखते, तो आपके हार्मोन्स को भी याद नहीं रहता। सो वो पोक देना, बहुत ज्यादा स्टडीज हैं, ऐसी भी स्टडीज हैं। देखिए मैं आपको एक बात बताता हूँ, आज एक और मैं बात बताना चाहता हूँ। एक कॉमन एग्जांपल थी, एक म्यूजिक लर्न करना जो है ना एक फाइन आर्ट है, राइट। जब आप म्यूजिक लर्न करते हैं ना, तो टोन एक स्पेसिफिक बजाना ना, एक बंदा या बंदी फंस जाते हैं। तो कोरियंस और जापानीज पता है क्या करते थे, वो प्रैक्टिस करके सो जाते थे, और जब अगले दिन आते थे ना वापस, तो वो टोन, वो स्किल्ड मोटर ऑटोमेटिक वो बजाना शुरू कर देते थे। अक्सर आपने भी देखा होगा ऐसी चीजें। वो क्यों किया ऐसे? वो इसलिए हुआ है कि आप जब सोए हैं ना, तो वहां पे उस पे आप लर्न कर रहे हैं, स्लीपिंग में लर्निंग हो रही है, इस वजह से आपको याद रहा है। और इसलिए जब आप वापस आए हैं ना, तो आपने वो स्किल्ड एक्वायर कर लिया हुआ था। सो ये फिर इसीलिए मैं ये एम्फोसिस करता हूँ कि बच्चों के लिए और बड़ों के लिए भी, बड़े अगर ये नहीं करेंगे तो इस मुल्क में तो बाबा डिमेंशिया के बहुत ज्यादा इश्यूज हैं। और मुझे नहीं पता बैक होम कितने हैं, क्या बाबों के साथ करते हैं, उनको याद रहता है या नहीं रहता, लेकिन एक बहुत बड़ी को रिलेशन है। ओके, स्लीप, सोना लाजमी है और उसको भूलना भी नहीं है। सो ये दूसरा टिप हो गया। तीसरा टिप हो गया, आपका बॉडी टेम्परेचर स्लीप में गिरता है, आपको याद रखना है। और गर्मी में सोना इज वेरी हार्ड। सो जितना भी कूल कर सकते हैं ना टेम्परेचर रूम का, रात को एक्स्ट्रा करें। ब्लैंकेट लेना इज एक्चुअली अ गुड हैबिट। जब आप रेम स्लीप में जाते हैं ना, तो आपका बॉडी टेम्परेचर और गिर जाता है। एक्चुअली उस वक्त आप टेम्परेचर वाइज लूज करते हैं एनर्जी। सो ब्लैंकेट रखना अपने साथ इज एक्चुअली अ गुड हैबिट एज वेल। सो जस्ट मैं आपको ये बताना चाह रहा हूँ, कूलर एनवायरनमेंट में जितना भी कर सकते हैं, और ब्लैंकेट लेना अगर पॉसिबल है करें। मुझे पता है गर्मी है बैक होम पर, आपकी स्लीप उससे अफेक्ट होती है। सो आपको ये याद रखना है। और ये हम थोड़ी सी बातें कर ली हुई हैं, एक इलेक्ट्रॉनिक्स टीवी वगैरह प्लीज कोशिश ये करनी चाहिए कि बेडरूम में ना लेके जाएं। और टीवी को तो वैसे ही निकाल देना, ये जो फैशन है, मैंने देखा लोग बेडरूम में टीवी देखना चाहते हैं, इट डजंट हेल्प। एंड अपने आप को रिमाइंडर देना। और एक और बात, स्लीप को अपने लिए ऐसा रूम कंसिडर करें कि आपको नींद ऑटोमेटिक याद आए। ब्राइट लाइट्स ना रखें। जब रात को बाथरूम में जाना होता है ना, तो अपनी टेबल लैंप को ऑन करें। और ब्लू लाइट रखना प्रेफर्ड है ओवर एनी अदर लाइट। सो ये इज वेरी इंपॉर्टेंट। और तीसरी चीज, कैफीन का इनटेक आफ्टर 3 बजे लिमिट कर दें अगर आपकी स्लीप इफेक्ट हो रही है, और अगर स्लीप रात को इफेक्ट होती है तो उसको अर्लियर बंद कर दें। और ये ना समझे कि चाय में और दूसरी चीजों में कोई इफेक्ट नहीं होता, हर चीज का इफेक्ट होता है। और ये भी ना समझे कि ओहो जी मैं तो रात को सो के पीता हूँ, तो अभी आप सो लो, लेकिन आपकी स्लीप डीप नहीं हो रही बाबा, सो रहे हो, क्वालिटी का नहीं पता, तो वो असेस करनी होती है, दैट्स वेरी इंपॉर्टेंट। और आखिरी बात ये है कि ह्यूमंस ही वही वाइफ स्पीशी है जो अपनी स्लीप को कॉम्प्रोमाइज करते हैं, बाकी कोई नहीं करता। सो अपनी स्लीप को रेगुलर रखें, और इस पे थोड़ा सा नजर सानी रखें। ओके, अपने जेहन में रखें कि ये स्लीप भी एक एंटिटी है, ये एग्जिस्ट करती है, याद करवाएंगे तो याद रहेगा। तो इसी के साथ अगर तो कोई क्वेश्चन और नहीं है, we're gonna conclude this. After this, if there's no question, I don't see any question in particular. Let me see if I can answer. It's just that my husband, because he's, what is this? The husband, is there any non-medicine solution for snoring? ये मुझे बार बार लोग पूछ रहे हैं कि स्नोर करते हैं, कोई दवाई बताओ, स्नोरिंग हो रही है, दवाई बताओ। बाबा, स्नोरिंग की दवाई कोई नहीं है। स्नोरिंग के लिए अगर दवाई, या ये वैसे आदत हमें थोड़ी सी ना जो है ना वो आदत है कि हम समझते हैं हर चीज पिल्स के साथ ठीक हो जाएगी, ये नहीं ठीक होने वाली इससे। इसके लिए आपको नजरें देखना पड़ेगा, इज इट फ्रॉम आपके वेट से आ रही है, आपके पैटर्न से, बिहेवियर से आ रही है, और अगर आ रही है आपका ऑक्सीजन कॉम्प्रोमाइज हो रहा है, आपको इसको फिक्स कराना पड़ेगा, ये इसका कोई शॉर्टकट नहीं है। ओके, सो जस्ट दैट यू नो अबाउट दिस। सो लाइफस्टाइल, और तीसरी चीज, एक और क्वेश्चन बार बार, मेरा मूड ठीक नहीं रहता, स्लीप से तो नहीं है, ये पूछ रहे हैं मुझे। ऑफ कोर्स mental well-being is very very important. Study after study after study है कि mental well-being is one of the biggest things that is affected by inadequate sleep. Not only inadequate sleep, but sleep deprivation, but also the quality of sleep. So ये ना मुझसे पूछे कि वो ये ना बताए मुझे मेरा हस्बैंड चिड़चिड़ा रहता है और लड़ रहा है मुझसे, तो स्नोरिंग की वजह से तो नहीं। ऑफ कोर्स अगर वो कर रहा है तो वो कुछ जाके फिक्स कराना पड़ेगा इसका। यस, और आपको मैं एक और मजेदार बात बताऊं, क्लिनिक में सबसे ज्यादा मियाँ जी जो है ना, मियाँ जी नहीं जाने वाले अपना घर, मियाँ जी को कौन घड़ीस के लेके आता है क्लिनिक में? उनकी बीवियां, वो कह देती हैं इसको पकड़ो ठीक करो, और बाबा जी हिलते नहीं है, वो बेचारे चुप करके वो मुर्गी की तरह वो सी पैड लगा के घर लेके जाते हैं कि मैं वापस आऊं, क्योंकि वो बेगम कह रही है भाई इधर तो पावर है उनकी, मुझे नहीं पता बैक होम नहीं है, तो इसीलिए ये स्लीप इतना बड़ा है। औरतें जो है ना वो शायद मुझे नहीं पता किसको बेडरूम से बाहर निकालती हैं, या बंदे को निकाल देती होंगी, या खुद बेचारियां चली जाती होंगी, एक ना एक तो जा रहा होगा बेडरूम से, क्योंकि आई कांट स्लीप विद स्नोरिंग, आई डोंट नो इफ यू कैन। मैं एक दफा वो अपने दोस्तों के साथ, एक छोटा सा किस्सा ये है कि मैं अपने दोस्तों के साथ वो हज पे गया, तो हमने जो है ना, मेरे बचपन के दोस्त हैं, तो हमने एक टेट्रा रूम 3 वाला रूम बुक करा लिया। मुझे तो पता नहीं था क्या होने वाला मेरे साथ, और जो ही मैं लेटा, वो गुड़गुड़ गुड़गुड़ उधर से आवाज आना शुरू हो जाए, गुड़गुड़ गुड़गुड़ इधर से आवाज, वो दोनों तीनों से सो गए, और मैं तो कंबल लेके वो बरामदे में चले गया बाहर, और मैं क्या, मुझे तो मैं कैसे सोऊंगा, आप लोग तो आराम से सो गए, गुड़गुड़ गुड़गुड़ गुड़ गुड़, वो तीनों। और दिल मेरा ये करे कि मेरे पास सीपैप हो, मैं इनके मुंह पे लगाऊं और इनको प्रेशर दे के ये क्या स्नोरिंग तुम लोगों ने शुरू कर दी है। अगले दिन मैं तो भागा, एक दिन जब जगराता हुआ मुझे, एक वैसे ही जेट लैग था, दूसरे दिन वो उमरा वो करना था, हज करना था, इधर दौड़ो उधर दौड़ो, ऊपर से नींद कोई नहीं, और फिर वो उठ के सुबह कहते हैं आमिर तुम तो यार बड़ा लेट सोते हो, हम तो फजर पे चले गए हुए थे, वो तुम लोग तो चले गए थे, मेरा उन्होंने झूमर निकाल दिया वहां पे रात को, मैं 4-5 घंटे इधर उधर देखूं, फिर मेलाटोनिन खाऊं, कभी ये तो ऊपर से वैसे ही जेट लैग, वो जो ना टाइम डिफरेंस। मुझे हो भी जरा काफी ज्यादा जाता है। तो मैं तो ये कह रहा हूँ आफरीन है हमारी औरतों पे जो उन मर्दों के साथ सोती हैं। और सो आई वांट टू गिव दैट, सो डोंट टेक इट। हाँ, अगर उनकी ब्रीदिंग नहीं ठीक हो रही देन इट्स एन इशू। और एक और मैं आपको बताता हूँ इसके साथ अटैचमेंट क्या है। मेरा एक दोस्त है, वो कार्डियोथोरेसिक सर्जन है, तो न्यू कासल से पढ़ के इंग्लैंड गया, इंग्लैंड से पढ़ के पाकिस्तान गया, और मुझे फोन करके कहता है कि यार आमिर आ जाओ इधर। मैंने क्या हुआ है? कहता है यार इतने इतने बड़े मैंने हार्ट यहाँ पे देखे हैं कि रे नाम अल्लाह का, 20-20 25-25 साल के हैं, सारे मोटे हैं, और दिल उनका डबल डबल है। वो बड़ा दिल होना हार्ट फेलियर की निशानी होता है। और वो क्यों कर रहे थे? इसलिए सर्वर मुझे कह रहा था क्योंकि उनको रात को वो सो रहे हैं अंडर स्ट्रेस, स्लीप एपनिया बहुत ज्यादा है, और उसकी वजह से यंग पॉपुलेशन में कार्डियोमायोपैथी इज अ लॉट। हार्ट हार्ट बड़े कार्डियोमायोपैथी, हार्ट अबनॉर्मेलिटीज हो रही हैं बहुत ज्यादा। एक रिदमिया होते हैं जो इलेक्ट्रिकल कंडक्शन नहीं ठीक होती, उसकी वजह से हार्ट स्टॉप कर जाता है, या हार्ट वैसे ही बड़े हो रहे हैं ओबेसिटी की वजह से। सो जस्ट दैट आई वांटेड टू शेयर दिस। मुझे अभी याद आ रही थी ये दो बातें स्नोरिंग से। So the answer to the question is जिन्होंने भी अटेंड किया उनको जरूर मिलेगा। सर्टिफिकेट वगैरह के पूछ रहे थे, हमारे पास ये लिस्ट है। So with whatever the list we have, we're going to send it to whoever attended this. Will get their certification for sure. Okay. And I think, and please make sure you don't come as anonymous or something that we don't know your name. So keep, because we got a list of all the names who have attended, and we definitely will be distributing the certificates out to them. And let me see if there's any other question. If any a question, then I'm just going to sum this up by having Dr. Hamza on the stage.
Thank you,
Dr. Hamza.
Khan. I hope everyone can see my screen. So guys, that was a wrap from the Sleep Webinar Texas Sleep team. And we hope you learned some awesome tips to catch those sweet sleep hours for your whole family. So a few thank yous before we end the show. I'd really like to thank you, the amazing panel of doctors who were with us today. You guys are really sleep rock stars. I would like to thank our hardworking HR team, which was able to gather a huge audience today. And it was really their hard work. I would also like to appreciate our creative graphics team who designed the presentations, the videos, and other media stuff for this webinar. And last of all, I'd really like to thank our amazing sleep webinar management team who did an amazing job in the past couple of weeks to successfully host this webinar. So kudos to you guys as well. And then lastly, thank you to all the audience who were able to join us today. I'd really like to appreciate the effort and the time that you guys put up with us today. And I'd like you to know that the certificate of participations will be sent out to you next week through emails, all of the guys who attended today. And then if you liked our webinar and you'd like to attend more events like this, so you can follow us on American Muslim Today 4498 on YouTube. Or you could follow our weekly podcast, Khan Clinics, on health and other societal issues, which happens every Friday live at 3 p.m. Central Time, which is 1 a.m. Pakistan time. So once again, thank you all for joining us. Thanks again, and sweet dreams to everyone. Much appreciated.
Jeremy is going to sign off in a minute, Hamza. Thank you, everyone. Thank you. Sign off. We'll just keep our Zoom panel here for a minute. I just want to thank them.